coordinator for this session is Spiridon Papaionou, the founder and chairman of the organizing committee of the Sports Cardiology Fanfare Congress. And now I'm kindly asked Dr. Spiridon Papaionou to come to the podium to introduce satellite session by Sports Cardiology Congress.
All right.
Good morning. Dear colleagues, dear professors, researchers, ladies and gentlemen. It's a great pleasure for me to welcome you here in Cyprus to the Satellite Symposium of Sports Cardiology. Sports Cardiology Congress was an inspiration I had a few years ago, which came through with the help of Professor Ioannis Patrikios and the support of Professor Philippos Triposkiadis and Michael Papadakis, who are co-presidents of the organizing and scientific committee and honor us with their presence today among us. Sports cardiology is a new field of cardiology which aims to describe the benefits of regular exercise and physical activity and the prevention, the treatment of cardiology diseases of athletes. With these few thoughts, I shall open the Satellite Symposium, which for sure will be both successful and enjoyable. Thank you very much.
We would like to welcome you to this third session of our Congress. The topic of the session is sports cardiology. We have two very distinguished guests. Our first speaker is Professor Philippos Triposkiadis. I think that the professor does not need any references. He's very well known here in Cyprus. And he will tell us about exercise and the heart. How much? 1 metron aristou.
Thank you very much, Mr. Chairman, for your kind words. I would like to express my sincere thanks to my very close friend, Professor Patrikios, for the kind invitation. And I'm very glad to be here with you today, together with very good friends, Dr. Papaionou and Dr. Michalis Papadakis, who honor our countries in Europe. Well, I'm going to start with this slide. It's a group of, I would say, young guys jogging by the seaside during the sunset. And I would like to ask you something. Is it healthy or unhealthy, what they are doing? Is it healthy?
Yes, of course. Yes.
Of course. Okay. It is definitely healthy, okay, because moderate exercise, okay, improves the cardiovascular risk factors, improves inflammation and autonomic function, and also the vascular function and the cardiac function. And the result is a 35 degrees in major ischemic cardiovascular events and the 40% decrease in cardiovascular mortality, and also a lifetime decrease in the risk of heart failure. Now, the next question. You see these two guys? They also exercise. They are marathon runners. What they do is healthy or unhealthy? How do they look to you? They are both exhausted. So when we are talking about exercise, we have to get to also to discuss about the volume of exercise, okay? And every kind of exercise has two components. The one component is static and the other is dynamic. And there are some types of exercise, like this one here, cycling, canoeing, and decathlon and stuff like that, in which both components, both the static component and the dynamic component, reach their maximum, okay? It is in these athletes that you see this change in the heart thickness and dimensions. You see that the heart is dilated, and you see that the wall of the heart is a little bit thick. Now, we call it athlete's heart in most of the time, of the cases. But I'm going to show you to you that there are overlaps. And there is also an inter-individual variance to what happens to the heart. You see, we have 3 cases here. All of them are endurance athletes. And you see that the first one, who is, okay, the first one, a triathlete, okay, has a normal thickness of the IVS, the interventricular septum, and the dimension, the volume of the left ventricle is normal. And here we have a competitive cyclist with the same thickness of the septum, but the dimension of the left ventricle is greater. And then we have another one, cyclist, has a more thick interventricular septum, and the left ventricle is more dilated. What does that mean? It means that what we call inter-individual variabilities have to do with genes. And we know very well that genes regulate the remodeling of the heart, the metabolism, and most of the functions of the heart and the body. You see here, okay, autonomous nervous system, salt and water retention, myocardial subset, and everything regulated by the genes. Okay. And now it comes to the main focus of today's lecture. And you see this curve here, what it shows. It's a curve. On the x-axis, we see the volume of exercise, and on the y-axis, as the risk is depicted. And you see a Y-shaped curve, this one here. And up to this point, we have a decrease in risk. But from here on, as exercise increases, the risk increases. And this is a hypothesis that when we endeavor with extreme sports, then the risk may increase. This is a hypothesis. Now, do we have some evidence that this may be true? We definitely know that everything, almost everything in life is controlled by the environment and genetics. And the same is true here in exercise. The response of the cardiovascular system is controlled by the environment and the genetics. And sometimes it shifts towards physiological, but sometimes it shifts towards pathological. Okay? And let's check these triathletes. These are 40 years old, as I see here, okay? And in 83 asymptomatic triathletes exercising, as you see here, okay? More than training hours per week, that out of 9 of them, 14%, have fibrosis in the heart. And this fibrosis, okay, it spends only the subendocardium, which is something that occurs with fibrosis, which is due to ischemia. So I don't believe that there is someone here that believes fibrosis, that's a good thing. And let me show you something. in cardiomyopathies, in all cardiomyopathies, dilated hypertrophic cardiomyopathy, arrhythmogenic cardiomyopathy, in all cardiomyopathies, when fibrosis is present, then the risk of deterioration of cardiac function and malignant arrhythmias dramatically increases. So by no means one may consider fibrosis a good thing. In itself, in my opinion, fibrosis is a complication. And so which are the reasons? And now you can see the reasons here of the right ventricular insertion point fibrosis, which is considered normal. And the reason for this fibrosis is that during exercise, the systolic stress of the right ventricle may increase by 30 times, okay? And another reason for fibrosis is, in some patients, is subendocardial fibrosis, which is due to ischemia, and the fibrosis, which spurs the subendocardium and usually is present in subepicardium, and sometimes in mid-wall is due to myocarditis. So this is found in triathletes. And now I'm going to show you something that is related with genes. This has nothing to do with exercise, but it is an introduction to the next study that I'm going to present to you. This is a polygenic risk score that predicts the risk to develop dilated cardiomyopathy. It is called the left ventricular and systolic volume index polygenic score. And as you see, as it increases, and this occurs in 10% of the patient, the risk of developing dilated cardiomyopathy increases. And so you are going to say, why are we talking about this score and dilated cardiomyopathy? And now, because I would like to show to you this very recent study in which the investigators determined the ejection fraction in almost 300 elite young endurance athletes. So you see, some of them, okay, most of them had a normal ejection fraction. You can see that here. These guys here, almost 84%. But there were some guys who reduced right or left ventricular ejection fraction, or both left ventricular ejection fraction. You see it here. So in these guys, what they did is they correlated the ejection fraction with global left ventricular strain, which is a better measure of systolic function and contractility than the left ventricular ejection fraction. And as you may see here, it is decreased in those with depressed ejection fraction. Now, what happens during exercise, you see that ejection exercise increased both with those with decreased and those with increased ejection fraction. It increased during exercise, but it still remains lower during exercise than in those with normal ejection fraction. The difference is that it increases more in those with reduced ejection fraction. And you are going to ask me, why do I have to see this? This is supposed to be normal. And if you see the characteristics of athletes, you are going to see normal or slightly reduced ejection fraction, because this is the first study that correlates the findings of ventricular function with the polygenic risk score, and those with the reduced ejection fraction had the highest polygenic risk score, meaning that they had the higher risk to develop dilated cardiomyopathy. Now, if you interpret these patients as normal, as patients having normal athletic heart, or that this is maybe they are at risk for something, and you cannot tell them normal. This is a matter of debate. Now, another problem with athletes is arrhythmias. And what I would like to tell you is, if the heart is normal and you find some ectopy, that's normal. If you have problems with the right ventricle measured by strain and ventricular arrhythmias, the risk is higher. And the highest risk, you find it here when the athlete has, problems with the left ventricle. And you see here that there is a scar in an athlete with ventricular tachycardia. So remember, the worst ventricular arrhythmias are related to the right ventricle. They are dangerous and very dangerous when there are structural abnormalities of the left ventricle. And now something, and I believe that, Michael, you were involved in this study, right? Okay. A very important meta-analysis that demonstrated what this one here, that in endurance and athletes have a higher risk of atrial fibrillation than non-athletes by 2.46% for several reasons, especially younger athletes. And last but not least, those that exercise, that the volume of exercise is high and they do it regularly, what they get after some years is plaques in the coronary arteries and coronary artery calcification, which was demonstrated in this study. And there are several reasons. And the cardiovascular risk factors that may be present. And also, remember that during exercise, and especially when in marathon runners, cyclists, the blood pressure is steadily increased. And also there is a pro-inflammatory state and parathormone is elevated. So with exercise, depending of the volume of exercise, we have adaptations that are normal, okay? Let's say left ventricular thickness, dilated cardiac chambers, all the chambers, and the increased peak oxygen consumption. But at the same time, you cannot say that myocardial fibrosis is a good thing, that increased calcium score is a good thing, or the development atrial fibrillation, one of the most difficult to treat arrhythmias, is a normal adaptation of exercise. And something that we forget is when we discuss about exercise, and unfortunately, when we discuss about clinical trials, we don't mention sex differences, and there are sex differences in men and women, and as you are going to see here, as always, women have better remodeling than men. The sudden death, acute coronary events, and atrial fibrillations occur less frequently in women. And also, this has to do with differences in baseline electrocardiogram. So, to conclude, ladies and gentlemen, definitely moderate exercise confers healthy benefits. We have to know that there is an overlap between extreme exercise and cardiological cardiomyopathies. We have to remember that there are sex differences in exercise cardiac remodeling, and now I believe that we have proved that myocardial fibrosis, atrial fibrillation, dysfunction, and coronary arteriosclerosis are present in the risk to be present in endurance athletes and higher. And this is by itself abnormal. In my opinion, that's a personal opinion, I don't need any further data. So this is my last slide that could replace the whole presentation. Please read the first line. For both excessive and insufficient exercise destroy one's strength, and both eating and drinking too much or too little destroy health, whereas the right quantity produces, increases, and preserves it. Αυτό ισχύει για όλα συμπεριλαμβανομένης της άσκησης. It applies for everything, including exercise. Thank you very much for your attention.
Well, thank you, Professor Triposkiadis, for the excellent speech. And we'll continue to the second speaker, a well-known professor, Dr. Papadakis, who is a professor in cardiology at City St. George University of London.
Fantastic. Thank you very much. Mr. Chairman, I would like to thank the European University of Cyprus and Professor Patrikos for the very kind invitation. So you heard about people who do exercise and may potentially have disease. Now I will discuss people who actually have a diagnosis of heart disease, and in particular heart muscle disease. These are my conflicts of interest. So I'll start with a case, which is always a good start to put it into practice. So we've got a 27-year-old IT consultant who plays semi-professional football, and he trains on a weekly basis. He plays weekly games. He goes to extra gym sessions. He never had any symptoms or any medical history, but he comes to you to be screened because his brother has now been diagnosed with hypertrophic cardiomyopathy, which we know it's an inherited cardiac condition. So he comes to you, and this is his ECG, and this is his transthoracic echocardiogram, okay? So I have not given you a subtle case. For those of you who are good at interpreting ECG, you will see that there are very widespread repolarization anomalies in the form of T-wave inversions that affect his lateral and anterior leads, with associated ST segment depression, T-wave inversion, and pathological Q waves in the inferior leads. And then if you look at the echocardiogram, this is your long axis view, this is your short axis view, and there is significant hypertrophy at the anteroseptum, which is about 21 millimeters. So Professor Triposkiadis showed you some athletes that may have 13, 14, 15 millimeters, but 21 millimeters, and particularly asymmetric hypertrophy is definitely pathological. So there is no doubt that this individual has also inherited the gene and has expressed the gene for hypertrophic cardiomyopathy. So the question is, how do you go about prescribing exercise? Can he continue with his football? Would you recommend something else? So we go back to basic principles, and the sports cardiology guidelines published in 2022 is a very useful document. So how do we go about assessing his individual risk? The first thing is go back to basics. You learn in your medical school to take a very comprehensive history. You need to know if he's got symptoms. You need to know the exact family history. Very important to know how much exercise he's currently doing, right? This guy who's already playing football all his life is different compared to someone who wants to take up exercise and has been previously sedentary. Then we'll perform the necessary evaluation and explain what I mean. Then we will optimize the treatment as a general principle, and then we aspire to provide them with as individualized exercise prescription as possible, in the same way that you would provide a prescription for a beta blocker, for any medication. So these are the guidelines I referred to before. If you haven't read the document, go and have a look at it. It's a very useful document. It is a lot of pages, as they usually see guidelines, but if you want to focus on hypertrophic cardiomyopathy, it's going to be a couple of pages with very succinct tables. And the nice thing about it is that it's moved from a very conservative and restrictive approach that we had before to a very liberal approach, acknowledging that we don't have many data that suggest that exercise and high-intensity exercise is detrimental for people with hypertrophic cardiomyopathy. And what are the studies that we currently have? In terms of recreational exercise, this is a very nice study by Sarah Saberi, where she split HCM patients to an exercise group and to a control group. They had a very specific exercise program at home. They were very closely monitored for arrhythmias, and at the end of the program, what they identified is that they can improve their fitness level. they can improve their quality of life scores, and they didn't see any evidence of malignant arrhythmias in the exercise compared to the control group. Remember, the question you're being asked, whether if I exercise, do I increase my risk beyond my baseline risk as a patient with hypertrophic cardiomyopathy? Now, this is a study that we've done, and hopefully will be published in the European Heart Journal very soon. And we did something similar, but because we do a lot of screening and we identify younger people who are potentially at lower risk, we decide to go for younger individuals between the age of 16 and 60, and we also decide to go from moderate to high-intensity exercise, defined as a target of 85% of heart rate reserve. Again, we randomized individuals to a group of essentially an exercise, like a cardiac rehabilitation program, and a regular treatment by the national health system in the United Kingdom. We had very good participation. As you can see, almost 80% completed our program as well, which is roughly what you expect for cardiac rehab programs. The encouraging thing was that we didn't see any increased arrhythmia comparing the exercise group to the control group. And the other encouraging thing was that we saw an improvement of their exercise capacity and their overall fitness, an improvement of the cardiovascular risk factors such as blood pressure, cholesterol, and BMI, which is particularly important if you've got a 20-year-old that has potentially another 60 years of life in front of him, and an improvement in the anxiety depression score. So even for high intensity, the message is very similar to what we saw with the Sudbury study in terms of recreational exercise. And finally, the latest study we've got from 2023, this is an observational study. This is the only way that you're going to get almost 1,700 HCM patients, okay? You have to do an observational registry, essentially. Important to note that vigorous intensity exercise is very well represented in this particular cohort. And the point that they try to make is that in the short term, about 3 years of follow-up, there was essentially no difference in terms of events, and they had very good, very solid outcomes in terms of cardiac arrest, ICD shock, sudden cardiac death, okay? And they didn't see any difference between the high intensity versus the more sedentary individuals with hypertrophic cardiomyopathy. So I will argue that in terms of recreational exercise, at the very least, you should recommend the WHO recommendations in terms of moderate intensity exercise of 150 minutes, supplemented by weight training, and also don't forget to advise your patients to reduce their sedentary time, okay? So ideally, if you were in a sports cardiology conference, you will not be sitting in your chairs. We'll have you all standing up and listening to Professor Triposkiadis and myself. Do we have any data in actual competitive athletes? And we do have some data. So this is the Pelliccia study. He took 90 athletes with hypertrophic cardiomyopathy, who after the diagnosis, 60 of them chose to stop competitive sport and 30 continue with competitive sport. And on a follow-up of about 7 years, what they identified is that there was no difference between the two groups. There were 2 cardiac arrests in the people who stopped exercising and not related to exercise. But for me, the most positive message in terms of competitive athletes is this study by Rachel Lampert, where they looked at 440 athletes who had an ICD. This is an athletes with ICD, with defibrillator study. So by definition, we're talking about the highest risk group. Now, who were the people who got more appropriate and inappropriate shocks? It was patients who had arrhythmogenic right ventricular cardiomyopathy. It was not the well-treated hypertrophic cardiomyopathy patients or patients with long QT syndrome, which is one of the ion channelopathies. So again, very encouraging news. However, it is worth remembering that we're talking about relatively small numbers, and we do get it wrong, and we're bound to get it wrong, and that's why it's important that shared decision-making model, that you communicate the certainties and the uncertainties that we've got in your athlete. This is a study that we published in New England Journal of Medicine of more than 11,000 adolescent football players, so all of them were around the age of 16, okay? They were screened. After screening, there were 8 deaths, out of which 3 were with hypertrophic cardiomyopathy, and those included 2 individuals who were thought to be low-risk hypertrophic cardiomyopathy, but unfortunately experienced a cardiac arrest while playing football at a later stage. So a word of caution there. So how do we go about it? 1, perform your comprehensive evaluation. That will include your history and physical examination. An echocardiogram is absolutely necessary. An exercise test, and ideally I like to do a cardiopulmonary exercise test, which gives you a much more comprehensive assessment of the athlete. ECG monitor, and now we've got those patches. We don't need to have halters that you've got the wires hanging. So people can take it and use it during a training session, because you cannot reproduce in your office the training or the game of a football match. There is no way you're able to do that. And potentially a cardiac MRI looking for fibrosis or ischemia. Then you can input your data in that freely available ESC calculator, which essentially will give you the risk of sudden cardiac arrest or sudden cardiac arrest, death, over the next 5 years for your athlete, okay? It's not aimed at athletic individuals, that's aimed at the general population, but that's the best tool we've got available. And then, as I said, you can have a discussion with your athletes about the risks versus benefits, and that can be very different. So if you've got a 22-year-old whose whole life depends on his football career, it's a bit different compared to the IT consultant that I've got here who pays semi-professional football player, and that may affect how that shared decision-making model works. What are the recommendations in terms of the European Society of Cardiology? As I said, a bit more liberal, so people who don't have any high-risk features, such as significant symptoms or family history, elevated TSE score, significant gradients across the left ventricular outflow tract, abnormal blood pressure response to exercise or arrhythmias during exercise, they could potentially continue with participation in competitive sports, while individuals who have high-risk features, they are advised to do more recreational, moderate intensity sport. In terms of those who are genotype positive, but they have not expressed the phenotype, we treat them as relatively low-risk individuals. Then give that exercise prescription. That's the sort of thing that you need to use, okay? Exactly as you will do for your beta blocker. What sport, how often, how long should be each session, okay? And when are we going to review our prescription again? In 3, in 6 months, so on and so forth. And please try and be as specific as possible. And that's why the ESC guidelines are very useful, because they've given you lots of ways to communicate intensity and sporting activity to that particular individual. And then don't forget that once you've done that, the job is not done. Ensure that appropriate monitoring and review of the athlete to reassess the risk, as well as the appropriate emergency response planning, and that's why sometimes it's much better for someone to play football in an organized activity, whether that's in the university, the school, or a team, rather at the back alley of his house, okay? And inform them about symptoms that should make them stop and come back to you for reassessment, such as palpitations, syncope, chest pain. Word of caution, make sure you get the diagnosis right. Athletes get hypertrophy, as Professor Triposkiadis said. Not all hypertrophy is hypertrophic cardiomyopathy. Make sure you don't mislabel someone. Be aware of increased risk in the younger individuals and those start-stop sport, like the football that our player is playing, and question what you're trying to achieve, as competitive sport does not equate exercise for health. And just before I finish, I would like to say that the one cardiomyopathy that we're still a bit more conservative is the arrhythmogenic right ventricular cardiomyopathy, and that's because here we've got reasonable evidence that suggests that high intensity and duration of exercise may have a detrimental effect in terms of the progression of the condition and causing malignant arrhythmias and sudden cardiac arrest. So to finish off, cardiomyopathy and exercise, everyone should definitely be exercising, but competitive sports should be viewed on an individualized basis. And if you're interested in sports cardiology, we run an excellent MSc program at St. George's University of London. Thank you very much for your attention.
Well, thank you, Professor Papadakis, for the excellent presentation. We have time just for one question. Please, ladies and gentlemen. Yes, the lady.
Dr. Trifonos, I'm a clinical exercise physiologist. Thank you both for the excellent presentations. I just have one question. What about, I was impressed with the increased risk for coronary atherosclerosis in patients, with the athlete actually. What could be the mechanism for that?
Sorry, go again. So the question is about coronary atherosclerosis?
Yes, that we just heard that the athletes might have higher risk for coronary atherosclerosis. And I was just a bit, given the so many benefits that we have of exercise in atherosclerosis, I was just wondering what could be the potential mechanism for that?
Yes, so the data we've got say that obviously exercise is good in terms of cardiovascular disease prevention, including atherosclerosis. We do have some evidence, and that's what Professor Triposkiadis was trying to communicate, that athletes get more plaques, and they're not necessarily, as we probably thought initially, the stable calcified plaques. Now, a plaque is pathological, as Professor Triposkiadis said. However, again, the important thing to note is, because what we're interested is in outcomes, right? What does that mean? Are you going to get more heart attacks? Are you get more arrhythmias? And the evidence that we've got currently is that probably that increased prevalence of plaque and atherosclerosis is counterbalanced by the increased fitness levels. So there are some population studies that have separated people by the level of exercise and the fitness levels, and you'll see that the curve goes something like that. So people who are fitter with the same sort of plaque or calcium score tend to have less events.
Thank you very much.
Professor, thank you very much for the excellent presentation. Let's say we have a young athlete who is 20 years old. He suffers from hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy. And he comes to our office, to our practice, and he asks.
Can we fix the microphone?
And he asks for if he suitable for competitive exercise. Let's say football twice a week, okay, 3 times per week, football. And according to what you told us, there's not increased risk comparing to the non-competitive sports for a young athlete with hypertrophic cardiomyopathy. My question is about the follow-up of this patient. How many times per year, months, should we follow up him? And with what should we see?
So,
2 years, let's say, every 3 years, when magnetic resonance imaging.
So
how many times should we perform ultrasound? Every 6 months, if he's a competitive athlete and he suffers from hypertrophic cardiomyopathy.
So to answer your question, there are several parameters that come into it, and age is a very important one. A 16-year-old with hypertrophic cardiomyopathy is a much more concerning case than a 46-year-old who plays recreational football, okay? So I'll be much more worried about the 16-year-old. Usually the way I go about it is I have that discussion with them. What's beneficial in terms of physical activity and exercise? And if possible, I will probably try to get them away from that start-stop thing that football has, okay? However, if he wants to continue with that, then we'll have that discussion. He may well continue with that if he's perceived to be at low risk. And then again, how often we see him will depend on his age and his initial feature. Sorry? Yeah, so for someone like that, usually what I'll do if he plays competitive football, I'll do the full evaluation at 0.0. I'll see them again in 6 months. I won't repeat the MRI and everything. I'll do an ECG, I'll do an echo, and I'll do an exercise test and an ECG monitor. Okay, it's the arrhythmia that concerns me most. And then I will probably go to annual follow-ups for that particular individual with a request if he develops symptoms to come back to us. Yes, but you'll do the MRI at time 0, and then you don't need to do the MRI every 6 months or every year, okay? So you can do it potentially every couple of years, or if you see that something has changed now in terms of either your echocardiogram or the arrhythmia burden that you're seeing on your exercise test or your Holter monitor. But that thing that people do MRI every 6 months and they hope that it's going to give them an answer, it's unlikely, it's highly unlikely.
Professor Triposkiadis and Professor Papadakis, thank you very much for excellent presentations.
For the next part of this session, extraordinary participation, heart failure, we'd like to invite chairs, Dr. Theodoros Christodoulidis and Dr. Vasilis Barberis to the podium, please.
So good afternoon, everybody, dear colleagues, friends, and students. My name is Vasilis Barberis, and on behalf also of my co-chair, Theodoros Christodoulidis, I welcome you to this session, which, of course, the Congress is in general of high level, but for us in the field of heart failure, this is indeed a special contribution. And that is because we have as guest speakers not just a couple of heart failure experts. We have some of the most influential doctors in the field globally. So without further delay.
Good afternoon from me as well. I totally agree with Vasilis what has just said. We have some very important speakers right now. And I have the honor to present the first one, which is Dr. Stavros Dragos, who is the medical director of a cardiac mechanical support artificial heart program and co-chief for heart failure and transplant and director of research for cardiology division. He holds the chair Edna Benning presidential chair, and his research interests are focused on myocardial recovery in chronic heart failure and in the acute setting as well. And Dr. Dragos' team is utilizing clinical and biological information derived from studies in humans and small or large animal heart failure models to understand and enhance myocardial recovery, which is exactly the topic he's going to talk to us about right now. So I invite Dr. Dragos.
Good morning. Can you hear me?
Yes, we can hear you very clear.
Thank you. Well, thank you so much for this opportunity to the organizing committee and Dr. Patrikios, and also thank you to Dr. Barberis and Christodoulidis for the introduction. It's early, it's 4:20 in the morning here in Salt Lake City, Utah. It looks about as you see here in the picture. We are moving from in the middle of the fall now. The colors are changing in the mountains right behind us. And of course, I would have rather been in my home country, Cyprus today, But I hope that next time we will do a good job today, and next time Dr. Patrikios and the committee will invite us again. Of course, I didn't disclose to my family in Cyprus that I am doing this today online and not there with them, which I would love to, but unfortunately I cannot. And so we will talk today about heart recovery, what we have learned, and what are the future directions that we are and others following in this field. Here we can see in this table several of the etiologies that they cause the heart to fail. You can see them in this red box there. And the purpose of this is not to go through all of these details. It's a busy table. It's just to make the point that the therapies we are using in these patients, the response rates that you see in the other column, the timing to response and the durability of this response are all variable. And this is a good reminder that the disease we are dealing with, which is an epidemic as we know, is a heterogeneous disease. We get reminded about this more frequently in HFpEF because of the lack of therapies. We just got one that showed significant outcome benefits, the SGLT2 inhibitors. The fact that we got a few therapies that they work in HFrEF earlier maybe has made us forget that HFrEF, which is the other 50% of heart failure patients, is also a very heterogeneous disease. And we will come back to this point. Here, in this image, you can see in the outer ring all of the mechanisms here that they are responsible for the forward process of cardiac remodeling and heart failure. And in the inner ring, you can see all of the things that we do on our daily practice in our hospitals and clinics to reverse remodel the heart. You can just, as you go around and look at these abbreviations, remind ourselves that the failing heart can get better when we do cardiac resynchronization therapy, when we fix the aortic or the mitral valve, when we do pharmacological interventions with beta blockers or RAS blockade or ARNI, when we control the tachycardia in tachy-induced cardiomyopathy, and all these other things that you see listed here. So which of those interventions and models could be used as an investigational model to help us derive more clinical and mechanistic insights in order to understand better how the heart can get reverse remodeling and recovery and improve the outcomes of this devastating epidemic, chronic heart failure. And I'll submit to you that the cardiac assist devices or left ventricular assist devices is one of these ways. And when we're talking about this, we need to remind ourselves of the classic model where the increased load on the heart is central to the process of forward remodeling. And you can see how the concept was generated here, the hypothesis that by removing a significant part of this load with the left ventricular assist devices, the concept is simple, right? The LVADs get the blood from the apex to the pump, and from there with a graft to the aorta. So they remove a significant load, part of this load from the heart. The issue is whether we can see reverse remodeling and heart recovery. Now, on top of removing a significant part of the load, these devices, of course, also improve the systemic perfusion and the neurohormonal milieu, which is the neurohormonal milieu is what we really target in our therapies as we try to improve these patients. This is an example of one of our patients where you can see here in the 4-chamber view how the heart was very weak when we put in the left ventricular assist device. In this case, was implanted as a bridge to heart transplantation until we find a donor in these advanced heart failure patients. That's one of the major ways we use these left ventricular assist devices in our heart failure programs. And you can see here how a few months later, the heart in the 4-chamber view is beating so much better. We call this patient responder. And here you see another example of another patient with similar heart failure etiology, idiopathic dilated cardiomyopathy, similar duration of disease, about 2 years, and similar duration of the intervention where the heart didn't really improve. And when we began in our center and elsewhere, and we started this work from the time I was at the University of Athens working with Sir Magdi and the late Professor John Nanas, we were really stricken by these responses, these differential responses. And of course, trying to understand why these two hearts responded differently is one of the things that we will discuss today, and as you can imagine, has far-reaching clinical implications. So the program we put together when I was recruited back to the University of Utah, I did here part of my training between 2001 and 3. Then I went back to Greece to start the LVAD and the artificial heart program there. And then 7 years later, Utah recruited me back to start the Utah Cardio Recovery Program, which has a clinical and a scientific component, which is a wonderful collaboration between many centers in the US and Europe and beyond. And so I'm going to try to present today some of the data that we have related to heart recovery and reverse remodeling. And I'm going to start with the summary of the data that I'm just going to show a little bit of them, but the summary I'm going to start with, these are our past research fellows and mentees who most of them now are faculty either in the United States or Europe, including Greece. Hopefully we will have one and send back to Cyprus as well soon. These colleagues who now finished or are still working with us as a junior faculty part of their research, one of the things that they identified with our team is that this phenomenon of reverse remodeling is not like pregnancy or death. It's not an all or none. It's a continuous spectrum like most biological phenomena. These are the percentages that you expect to see of patients that they respond or they have partial response or they don't respond when we do these studies and we unload their hearts. And another thing that I'm going to show you a little bit of data is the sustainability after you remove the LVAD. How durable is this reverse remodeling and recovery? And it's exceptional. And how consistently is reproducible this in single and multi-center studies and registries, which is very well reproduced. And of course, the predictors before the intervention, so you can do the patient selection when you're dealing with them. This is the Restage study, which was a multi-center study that was published about 3 years ago. We did it with the institutions that you see listed here. And these were the inclusion criteria in this study. I just went fast forward there. We don't have time to go through everything and all of the single center studies that led to this study. And in this study, we included patients with less than 60 years old, non-ischemic cardiomyopathy, weak hearts and dilated, and with chronic heart failure duration less than 5 years. These were the baseline, some of the baseline characteristics reflecting this inclusion criteria, as you can see here. And this is what it takes in order to have a recovery program. It's not rocket science. We just need to do what we're supposed to do on all of the HFrEF patients. We're supposed to do the 4-pillar GDMT, like the guidelines tell us, and we're also supposed to take a look at the heart every few months while these patients are all the LVAD. It's a practical and simple way. Sometimes people hear all these things and they think that we're talking about science fiction and very complicated stuff. This is just simple stuff. After you put in the device, you just need to follow and monitor the heart and do full GDMT per guidelines. And as you follow these patients, when you see the echo reaching more than 45%, as we know, these patients usually they have very low ejection fractions. When you see that, then you can go to do the weaning evaluation, which is also not very complicated. You just need to turn down the pump to the minimum support and load the heart to see what the heart can do when it's loaded. And you do that with an echo, you do it with a right heart cath, and you can also do a cardiopulmonary exercise test. These are the criteria that were used in this trial, the restage trial, and most of the centers are using. You need to normalize the dimensions of the heart during these weaning studies, and you need to see the echo staying more than 45% EF. And of course, the hemodynamics to normalize. A new thing that we're doing now, instead of just turning it down for half an hour or 1 hour, we let the patients in the ICU with a Swan Ganz catheter, and we just follow them for 1 day with the pump there turned down to the minimum to see that these results hold. And if this happens, then we take the pump out. This is the trial and how the echoes improve. This is the ejection fraction over time. Some patients improved, some patients did not. The core lab was in New York. And here is the dimensions of the heart, and systolic and diastolic, and how these also improved over time. And what happened with the patients that they met these criteria in this study, almost 1 in 2, almost 50% met the criteria, and we removed the LVADs for recovery, and we left their patients with their native heart. And so the question comes, what happens, of course, after you remove the heart? And I'll share with you some of these data. But before I go to the durability question, before I go to the durability and how durable is this recovery after you remove the LVAD, right? I would like to address one more question, which is relevant in the field. This study and most of the studies that preceded were studies that they were in selected patients, younger, non-ischemic cardiomyopathy, and with duration of heart failure usually less than 5 years. And the question in the field, of course, is how about all comers? How about all of the patients that we evaluate in our programs for advanced heart failure therapies like transplants and LVADs and all these things, including the ischemic cardiomyopathy patients? So this is a study from the National Registry in the United States called INTERMAX, where when we did it, this is one of our prior fellows who is now faculty, and Omar Weaver-Pinzon. When we did that study, we looked at the 15,000 patients. Now we have more than 25 in the registry. And on those, in this study, as we know, most centers at that point in time, this was new, it was not in the guidelines yet, they were doing only 1% of the patients where the pumps removed for recovery. So we focused on the other patients in the registry from all over the country, and we saw that at least 7,000 of those, they had follow-up data, follow-up echoes uploaded there. And so what we found in these, when we looked at the echoes they were uploading there, was that there was another 12.6% that they improved more than 40%, and that's the total, which is very significant. And of course, we also found another 30% of the patients that they had partial improvement, and they had a median change in the EF of 9% and a range of 6 to 14%. And again, these were echoes that were performed, read, and reports were uploaded in INTERMAX by all of the programs in the country. And that's the answer to the question, what are the rates you expect in advanced heart failure, all comers? The Columbia group got the same data from the registry a little bit later, and they did the same analysis, and they found the same results, of course. And this was published as well. Now, how to define recovery, which is related to the question I'm about to address, the durability of the response question, right? So I had the honor and the privilege a few years ago to get 35 of our colleagues, clinicians and investigators in the NIH in order to address this. And one of the things we addressed in this working group was how to define this recovery. And we all agreed that on top of just seeing the heart getting better, the structure and the function of the heart, we should also prove and investigate and show sustained remission from recurrent heart failure events. And the recommendations of this working group and the conclusions were published in the flagship journals that you see there of the relevant cardiovascular societies of surgeons, cardiologists, basic science, and bioengineering. Now, the durability question. If you're going to do that, and do all this work and then remove the pumps, and heart failure comes back within 6 months or 1 year, it's not worth it, right? And this is one of the first studies that were done. This is my mentor, Sir Yacoub, and this is Emma Burks, who was a fellow. I was a fellow as well when we started working on it. And what they did here is took 40 patients that they removed the pumps, and they compared them with 52 patients that the pumps were bridged the patients to transplant, and they compare their outcomes, and you can see here that they are comparable. And that was an early study. Other single center studies showed similar findings. This is a table summarizing these findings, which were excellent, but the numbers were small. And when you say new things like and things that they are not mainstream, you need to show big numbers so people can see these being reproduced in many centers and with big numbers of patients. So that's why we did this registry that I have the honor and the privilege to direct with the steering committee of the registry, where you can see now we have more than 55 sites and now more than 60 sites and more than 800 patients from all over the world that we are following prospectively and chronically. You can see the participation from North America, Europe, Israel, and Japan, and we are adding more studies and sites now from Asia. And this is one of my mentees, Neil Patel, who is now in Montefiore, and he's co-directing it with me. And if anybody has such patients in the audience, or we collaborate with centers and they don't know about it, please send them our way. And these are the patient characteristics of the registry. Importantly, almost 1 in 3 patients were older than 50 years old. And these, again, are selected baseline characteristics. And importantly, 10% of the patients were ischemic cardiomyopathy. And I say that because we sometimes label ischemic cardiomyopathy patients as patients that they cannot really improve, and their heart cannot improve. So we thought a lot about what could be the comparator when we see what is the durability of this reverse remodeling and what are the outcomes. And we thought that a good comparator, a good control group, like the study I showed you from Herfil and Sir Yacoub, would be to take the alternative therapy, which is the transplant we do in these patients when they don't recover, and just see what happens to the ones that we transplant versus the ones that we remove the LVADs. And we match the characteristics, as you can see here, propensity matching, and you can see the results we presented at ESC a few months ago, and the paper is under review right now. Very It's not a super duper complicated thing. It's something that happens with hundreds of surgeons and cardiologists being involved, and it's something that we can disseminate further. This is our steering and publication committee. We presented at the last International Society of Heart and Lung Transplant and ESC several projects that we're doing now, part of this registry. We have working groups that they are focused in each part of the process, how to wean the patients, how to treat them after you wean them, how the surgical approach should be, and the genetics and how these affect the durability. This is one of the projects we presented in ESC, which was we talked earlier at the beginning of the talk about how heterogeneous is this disease. You can see here the heterogeneity, right? And we wanted to see how this will affect the outcomes over time. And we didn't find any changes in the outcomes, regardless of the etiology of heart failure. And here is the ejection fraction, how it evolved over time. How to remove the pump, explant or decommission, that's another question that you can see here. It's about the same. And it's more simple, instead of removing the pump surgically, to just decommission it. Now, the exercise capacity is also an important question in the quality of life. And in this study from England, you can see how with blue are the healthy volunteers, and the ones that they explanted with orange, they had similar exercise capacity as those. And the durability of this exercise capacity, as you can see here, is very good, excellent over the years. Now, how to put all this together when we're dealing with our heart failure patients? Dr. Barberis, Dr. Christodoulidis, they see heart failure patients all the time. they get them to their office or to their hospital, to their clinic. And we don't have a transplant program in Cyprus, as you know. And we trained, as you saw, Dr. Koyopoulou, Dr. Bonios earlier. Now they are in Onassis Center. Dr. Kapelios, he's also in Onassis now that we train here, and we help them return back to help our only heart transplant program. And Dr. Barberis and Dr. Christodoulidis will send these patients to this advanced heart failure program, the only one we have in Greece and Cyprus, to be evaluated for advanced therapies, right? That's what we do when the patients are end stage. And so the working group of the NIH, we reconvened a year ago in order to put everything together. And one of the opportunities that was identified, Dr. Stevenson, Dr. Morris Pagani, and Renee Wong, and another 30 of us were there, where we identified, as you see here with green, the opportunity to use MCS, stands for mechanical circulatory support, use the LVADs in order to, as a complement or alternative to transplant, and identify the patients that they have the increased possibility. So, and delay or obviate the heart transplant in them and send them to these advanced centers like the Onassis Center in Greece from Cyprus and be evaluated for both there. And essentially what this is saying is that if patient has high chance of recovery, may not be a good strategy to go straight to transplant. And maybe you could consider first the VAD and optimization of GDMT, and only if this recovery does not happen, then proceed to transplant. And this is especially attractive in young and middle-aged patients. And why this is attractive in young and middle-aged patients? Because now we know, we have 50, 60-year-old data from the registry that we know that the long-term outcomes of heart transplantation, including retransplantation, this is it. If you are 18 to 39 years old, you're going to get 13 years. And if you are 40 to 59, you're going to get 11. That's not your dream. If you're 20, you don't want to die when you're 40 or when you're 35. You want to live longer. And that's why this is now being discussed more and more. It's a win-win situation. You can avoid and postpone the serious complications of immunosuppression in young and middle-aged patients and undergo transplant if the heart failure recurs, may not. Then these donors are going to be used for somebody else. They're not going to be wasted. We have all these people waiting and dying on the waiting list. So everybody wins. It's going to reduce the waiting list mortality. And of course, help maximize the beneficial impact of both heart transplantation and LVAD. And the concept is not to get one versus the other, of course, but to maximize the benefit both for the patient you have in front of you and the ones that you have listed. So the question in the working group, and maybe you are wondering the same, can we identify these patients? Can we identify the probability they have to recover when they come to see Dr. Barberis and Dr. Christodoulidis or Dr. Simeonidis that I saw in the chairing a few minutes earlier, who was my roommate at the University of Athens when we were in the medical school. When they see these patients, can they estimate the probability? Or when they send them to Onassis, can they estimate it there and identify the patients and select them? So this is Dr. Bonios, who is now back in Onassis. When he was with us, he tried to select and find ways to select these patients. Rotational mechanics is one way, but this is complicated, right? Not everybody is doing rotational mechanics to see who are these people that they can improve after we put in an LVAD. We also try to do this with inflammatory burden studies. We started from the tissue. We went to the serum. We identified TNF-alpha and interferon gamma, that they can also predict this response. But still, when you are dealing with your patients in your office, you need a more practical and precise way to do that, a simple way to do that. And so that's why we did this predictor calculator that you see here. You see the sites, almost 900 patients, a multi-center calculator. And what this does, when you get the patient, you just put these four things there: the etiology, the gender, the heart failure duration, and the LV and diastolic diameter. And this calculates for you the probability. It's an example of a woman that she has an LVDD of 6.1, and she was sick with heart failure. You see the duration there, about 11 months, and the probability is 40%. This is another example, 44 months out, LVDD of 6.5, more dilated, 30%. And it's another patient who is more recent onset, only 6 months. The LVDD is not dilated yet, and the personalized probability is 50%. Now we're trying to put also the tissue findings we have in order to get a derived personalized prediction. And the guidelines have recognized these, and I had the honor to participate in the guidelines committee, and they now tell us how to select and how to optimize these patients, and of course, how to evaluate them for recovery. The audience is primarily clinical, so I'm just going to spend only a minute on the scientific component and what are the drivers of this reverse remodeling. We're doing a lot of work with many others. Here is Dr. Tseyu, one of my mentees who is now junior faculty with us, and her NIH grant is focused on this as well. And this is a summary we did with many other investigators that we collaborate from all over the world, an invited review paper where we summarize all of the biological changes during this process. And what we really do in order to understand the mechanisms is that we take the tissue when the LVAD goes in, the inflow cannula goes in, so the apex goes out, and then when we transplant or recover the patients, we take a second piece. We see what are the changes in the responders and the non-responders, and then we go in the lab, we do screening of this tissue there to see where the changes come from, which pathways they come from, and then we go do the mechanistic studies in small and large, in vitro and in small animals, and later in large animals, in order to find these drivers, these molecular pathways that can lead us to new therapies. We've done this now 2 or 3 times, and I'll share with you a couple of targets. We don't have time to go into the details, of course. We talked about the heterogeneity of the disease. We get additional heterogeneity in adults, and that's why we are focused also on pediatrics and animal models where the heterogeneity is less. These are some of the targets we identified over the years and we have published with Dr. Dorsatos, who is going to be the next speaker. We also work, he's going to talk about one of the targets we identified in collaboration with them in our patients, and Kruppel-like factor 5, and how we are putting everything together in order to identify. It's an example, and it ties well with this talk because you're going to see how we move to the mechanistic studies in order to identify these and others that we identified here with other collaborators as reverse remodeling and heart recovery targets. If you want to read more about this, these are the 2 invited papers, the clinical one and the biological one that we just published with colleagues from all over the world. We also do a symposium every year, and this year you can join online or visit us. And we usually have more than 900 people attending online or in person. In summary, we talked about predictors. We don't have time, of course, to analyze everything. I'm listing there a couple of more that we identified. We talked about the phenomenon which is continuous. We talk about the reproducibility. We talked about the sustainability. We talk about the biological targets that we are identifying in order to push it forward and identify new therapeutics for HFrEF. And of course, we would like to thank all of our collaborators at our institution and throughout the world for the work. Thank you for your attention.
Thank you, Dr. Dragos, for this very interesting talk. Actually, this therapy with LVAD is becoming frequent all done these days, and we have several patients in Cyprus as well, so these are topics that interest us. I'm really sorry that I'm not allowed to do any questions because of they are pressing us here for the program. I have a lot to ask you personally, but anyway, we have to thank you. We are very proud of your work, and we hope we have you in person in next year.
Thank you as well. And next year, I promise I will be there in person.
We hope. Thank you, Stavros.
Thank you, Stavros. Okay, we're a little bit late, so we have to proceed to the next speaker, and that is Dr. Konstantinos Drosatos, who is a professor of pharmacology and systems physiology in the University of Cincinnati College of Medicine, and he will speak to us regarding an innovative subject, which is Kruppel-like factor 5, a novel myocardial element of heart failure. Good afternoon. Hello, Dr. Drosatos. Do you hear me? Can you? Yes, I hear you very well. Good morning from Cincinnati. Okay.
I could start complaining that it's 7 o'clock in the morning, but I cannot do that because it's 5 o'clock in the morning in Utah, and it's actually a great pleasure to be here today, even remotely, and share our work about what we call our favorite protein, group-like factor 5. Dr. Drakos, as usual, did a great job in presenting the translational aspects of their work. I will drag you more to the dark side, to the preclinical work that we do in the lab. So in my lab, we work with energy, which I'm sure we all agree that is an important aspect in life for different reasons. And when we discuss about energy, we need always to think of the first law of thermodynamics, which more or less says that there is not de novo production of energy, but there is a certain amount of energy in the universe that converts from one form to the other. And we are all aware of how the plants use solar energy to produce nutrients and their energy for their functions. Animals, including humans, use energy from food that we convert to heat that maintains our body temperature, as well as to mechanical energy for doing all the body functions. So the main sources for making energy in the body are carbohydrates that provide glucose, triglycerides that provide fatty acids, and in some extreme cases, even proteins that provide amino acids. And all these nutrients are used in order to make ATP. And why I'm telling this? Because the heart is a major consumer of energy, producer and consumer of energy in the body. It has been estimated that the heart produces about 5 to 6 kilograms of ATP in order to pump more than 7,000 liters of blood per day. And if 5 to 6 kilograms of ATP does not impress you, I can tell that the equivalent amount of energy that gas fuel can produce requires consumption of about 25 to 27 liters of gas fuel per day. So if we had to go to the gas station to fuel our car, we would need more than 25 liters of gas per day. So the energy production machinery has several steps of regulation. It's actually a continuous flow of metabolites, nutrients, gases, that eventually end up to the formation of an important molecule called acetyl-CoA, which will be channeled to the Krebs cycle. I hope you all remember from biochemistry the Krebs cycle that provides the electrons that fuel the electron transport chain that ends up to the formation of biosynthesis of ATP. So I already mentioned that there are several layers of regulation of this process. One of these steps that I will focus on has to do with how the cardiac cells obtain either glucose or fatty acids that are the most important fuels for making ATP. So when we have a meal, blood glucose goes up, and of course it can be stored in the liver in the form of glycogen, but at the same time it stimulates the pancreas, which produces insulin that orchestrates glucose uptake by several organs, including the heart. In case when we sleep, blood glucose goes down, and in that case, again, the pancreas is stimulated to produce another kind of hormone, which is called glucagon, that will stimulate glycogenolysis and gluconeogenesis in the liver that will release blood glucose, again, to be used by the organs. So the lipids, which is the predominant macromolecule that the heart uses in order to make ATP, 70% of the ATP that is produced in the heart comes from oxidation of lipids. So the lipids come from three main sources in the body. One is the intestine that provides chylomicrons and triglycerides that are included in the chylomicrons. Similarly, the liver packages triglycerides in very low density lipoproteins, and also the adipose tissue contributes a significant portion of the lipids that are used in the heart in the form of free fatty acids that circulate in the blood bound in albumin. So if we get closer to cardiomyocytes, this is how the acids that come either from the hydrolysis of triglycerides that are carried by lipoproteins, chylomicrons, and VLDL, or free fatty acids that come from the adipose tissue, cross the endothelial cell barrier through a fatty acid transporter, and then they get to the cardiomyocyte vicinity. This is again CD30 free fatty acids in the cardiomyocytes. They can be stored in the form of triglycerides and then re-released as free fatty acids that are used in mitochondria for beta oxidation. So you saw in my title the name of the protein called Krupa-like factor 5. About 10 years ago, we started working with this protein, and we identified that this protein regulates the expression of another protein which is very important for the transcription of a number of genes that end up to the production of proteins that are important for fatty acid oxidation. So PPR alpha is considered a central regulator of fatty acid oxidation in the heart, and we found that KLF5 stimulates the expression of PPR alpha. So it's a regulator of the regulator. Krupa-like factor 5 is a member of a 17-member protein family, and there are all kinds of flavors in Krupa-like factors. They can be either transcriptional activators or transcriptional repressors. It's a typical transcriptional factor, so it has a domain that binds on DNA. It has a domain that interacts with RNA polymerase, which is important for the induction of transcription. And through work primarily in colon cancer, because KLF5 is considered an oncogene for colon cancer, there have been several post-translational modifications of the protein that actually regulate its activity. When we started working with this protein, not much was known about what it does in the heart. It had been shown that it's important for adipogenesis, promoting adipocyte differentiation. It was important for storage of lipids in the liver, also for regulating fatty acid oxidation in the skeletal muscle, but nothing was known about what it does in the heart, and particularly in cardiomyocytes. So after showing that KLF5 is important for regulating fatty acid oxidation and PPR alpha, we started thinking, since in heart failure, the energy production machinery is significantly affected, and it is mostly suppressed. So in heart failure, the heart cannot produce energy. So we said, if KLF5 is a regulator of the regulator of fatty acid oxidation and eventually ATP production, energy production, can it be associated with any type of heart failure? So we started working on diabetic cardiomyopathy. And we did that because 20 years ago, Dan Kelly had published a paper showing that this protein, PPR alpha, which as I said is the central regulator of the energy production system in the heart, is increased in a mouse model of type 1 diabetes. And this increase was associated with accumulation of lipids in the heart, increased lipid uptake, lower glucose uptake, and eventually cardiac dysfunction, which more or less imitates what happens in diabetic cardiomyopathy. So our first question was whether KLF5 is affected in human hearts of people with diabetes. So with the help of our collaborator, George Kararigas, who is now at the University of Iceland, we obtained cardiomyocytes from hearts of patients that were subjected to aortic stenosis surgery. And we separated those samples depending on whether the patients had or did not have diabetes. So we found that in these patients, when they had diabetes, KLF5 was more than 3-fold higher in their cardiomyocytes. So in diabetes, KLF5 was increased. So we are a preclinical research group. So we work a lot with mice, and we started working in mice to see if KLF5 is involved in diabetic cardiomyopathy, and primarily if it has a causative role for diabetic cardiomyopathy. So we induce either type 1 or type 2 diabetes in mice, and we do that for type 1 by injecting mice with streptozotocin that destroys the pancreas, so these mice cannot produce insulin. Or we induce type 2 diabetes by subjecting the mice to high-fat diet. And by doing that, when we do the type 1 diabetes, within 1 to 2 weeks, we see significant increase of blood glucose. It takes a bit longer for the type 2 diabetes. It takes about 4 months to see hyperglycemia. And within 3 to 4 weeks or 2 to 4 months in the two models, we can see cardiac dysfunction. So in both cases, when we had hyperglycemia, this is a type 1 diabetes model, we observed cardiomyopathy, and importantly, we observed significant increase of KLA5 in the heart. Same in the type 2 diabetes model. So in both type 1 and type 2 diabetes, we see that KLA5 is stimulated, which resembles what happens in humans. So this is how we started building this pathway. So in diabetes, we see upregulation of KLA5, and we see that this is associated with cardiac dysfunction. Question number 1, how is KLA5 regulated? Why does diabetes induce KLA5 expression? And question number 2, is the upregulation of KLA5 important for causing cardiac dysfunction in diabetes, or it's just a serendipitous change that has nothing to do with the induction of cardiomyopathy? So we are a molecular biology lab, so we work a lot with regulation of genes. One way to do that is to test the promoter of a gene, which is the regulatory sequence that controls the proteins that will activate the expression of the RNA of the gene. We found several potential binding sites for various proteins, depending on the sequence. But our attention is drawn particularly to 4 binding sites for a family called FOX. And the reason that we were interested in that is because when we have insulin signaling and AKT, which is a protein that is activated with insulin, is phosphorylated, this protein stimulates phosphorylation of FOXO1, which is the transcriptional factor, and keeps FOXO1 in the cytoplasm. However, in diabetes, when insulin signaling is not working, AKT is not phosphorylated, and this leads to dephosphorylation of FOXO1, and this is when this transcriptional factor goes to the nucleus and can activate gene expression. So we want to test if FOXO1 is associated with KLA5 expression. And we confirmed by doing several in vitro experiments that activation of FOXO1 leads to upregulation of KLA5, and we checked that FOXO1 actually binds on on 2 of the binding sites that we had predicted with our in silico analysis. So then we said, okay, if FOXO1 and KLA5 are part of the sequence of causing diabetic cardiomyopathy, what happens if we inhibit FOXO1? So we generated mice that do not express FOXO1 in cardiomyocytes, and we induced diabetes in these mice. So in these mice, we'll show lower KLA5 expression compared to the diabetic mice. And importantly, we did not see cardiac dysfunction, either systolic or diastolic. So the next question was whether the inhibition of FOXO1 is protective because it affects KLA5 or because it does a number of other things. So we followed 3 different approaches to explore that. One was to reintroduce KLA5 expression in the mice that do not express FOXO1 and are protected from diabetic cardiomyopathy, and we observed that by doing that, those mice are not protected anymore. So by re-establishing KLA5 expression in these mice, we see that the protection by FOXO1 deletion is lost. We also did the same in healthy mice, and we observed again that those mice develop cardiomyopathy when they overexpress KLA5 in cardiomyocytes, and also we generated a transgenic mouse line that just expresses KLA5 in cardiomyocytes at high levels, and these mice also develop cardiomyopathy. So the next obvious question was whether inhibition of KLA5 could be protective for diabetic cardiomyopathy. To do this, we followed 2 different approaches. One was to generate mice that do not express KLA5 in cardiomyocytes, and the other to treat diabetic mice with a KLA5 inhibitor. In both cases, we observed significant improvement of cardiac function. Actually, cardiac function was not affected when we inhibited KLA5 expression in diabetes. And the next question was, okay, how does KLA5 induce cardiomyopathy? So there are several studies showing that one of the pathological components of diabetic cardiomyopathy is oxidative stress. And oxidative stress has to do with the creation of toxic molecules called reactive oxygen species. And these have been associated with damage of mitochondria and a number of toxic consequences for cells. So we checked that in diabetic mice we do have oxidative stress. This is a stain that stains for reactive oxygen species. We see that in mice that overexpress KLA5 we do see oxidative stress. But when we inhibited KLA5, oxidative stress is gone. And we did that either with genetic models or pharmacological models. Oxidative stress is a very complicated balance of different proteins that contribute to the formation of reactive oxygen species. We checked for all of them, for the expression of all of them, and to make the long story short, we found that two pro-oxidant proteins are activated when KLA5 is active, and three antioxidant proteins are suppressed when KLA5 is active. And this is now published, so I will not spend much time on that. But we saw that KLA5 actually induces oxidative stress through activation of the protein called NADPH oxidase 4 or NOX4. However, when we treated our mice, the diabetic mice, with an antioxidant, we did not see complete restoration of cardiac function, which led us to the conclusion that something else is also happening when KLA5 is activated. So we're a lipid metabolism lab, so we did lipidomic analysis in the hearts of mice that either overexpress KLA5 or have diabetes and KLA5 is inhibited. And to make the long story short, we saw that overexpression of KLA5 results in the increase of the formation of ceramide species, which is a lipid species. And ceramides can be formed through different pathways, and there are three different enzymes that contribute to ceramide formation. We confirmed that actually KLA5 induces ceramide formation by activating the de novo ceramide synthesis pathway called SPT. And this observation led us to another project that we actually pursued along with the Stavros Drakos group, which is whether has to do with whether KLA5 is associated with cardiotoxicity, heart failure induced by myocardial ischemia. So Stavros Drakos provided sums from patients that he already described with ischemic cardiomyopathy. We observed that these patients have increased KLA5 expression in the hearts. We checked our mouse models, both in whole hearts and in cardiomyocytes. With ischemia, KLA5 is increased. Again, the obvious question, is KLA5 inhibition protective in ischemic heart failure? So we treated either mice with KLA5 inhibitor, or we use mice that do not express KLA5. In all cases, we saw significant improvement of cardiac function, and importantly, we saw significant improvement in survival. Stavros already made a nice introduction about patients with myocardial recovery, and we collaborated with Stavros' group, and we observed that the patients who have lower probability to recover after LVAD treatment have higher KLA5 expression in the heart. I will go very quickly through the other two projects that we also test the role of KLA5. One is ischemia reperfusion injury. A lot of cardiologists are in the audience, so you know that a significant part of the damage that happens in the heart with myocardial infarction is when the artery is reopened, and because of oxidative stress, there is significant damage. We did the same thing in mice, 30 minutes of ischemia followed by 2 hours, 12 hours, or 24 hours of reperfusion. And we had an interesting observation that during ischemia, KLA5 is going down, which was sort of expected, but during reperfusion, KLA5 starts going up 2 hours after reperfusion, 12 hours after reperfusion, but by 24 hours, KLA5 is again back to normal. So we inhibited KLA5 with genetic mouse models, and we observed that we have significant lower damage in the heart. Same when we treated mice with a KLA5 inhibitor just 5 minutes before we reopened the artery. We see significant lowering of myocardial damage, improvement in cardiac function. We followed these mice for 4 weeks to see if by targeting KLA5 just once prior to the opening of the artery, if we can improve, if we can alleviate cardiac remodeling. And this is what we see, improvement in cardiac function, less fibrosis in those hearts. And finally, we are now working on the role of KLA5 in myocardial aging. And we have shown that in aged mice, which have mostly diastolic dysfunction, this is a HFpEF model, we see increase of KLA5 in the heart as well as in isolated cardiomyocytes. And when we inhibited KLA5 either genetically or pharmacologically, we see significant improvement in cardiac function and also improvement in oxidative stress. So I hope that I convince you that KLF5 is an important transcriptional factor for different types of cardiomyopathy, and my lab is still working on that, and we are now exploring ways to inhibit KLF5 also in large animals and see if by blocking KLF5 we can alleviate heart failure. So of course, a lot of thanks to the people who have contributed in our studies. Many people who have worked in my lab, either work now or have worked in the past, and of course our group of collaborators. And thank you for this kind invitation and for your attention.
Thank you very much, Professor Drosatos, for sharing your innovative research. Unfortunately, we don't have time to discuss, but I thank you indeed, because as our main audience here are students, you illustrated very nicely how from basic knowledge of biochemistry and physiology, one can at some point proceed to very innovative research, basic science research, and help at some point in the understanding and maybe the treatment of clinical syndromes like heart failure. So the message to the students is stick to your classes and your study in order to build for the future and do these admirable studies that Professor Drosatos has done. Thank you very much.
And please, if I may add something from the students, please be patient. It takes years for the preclinical studies to translate to clinical application.
Okay, perfect. Thank you very much. Bye-bye.
And now I have the honor to invite our last speaker, Professor Gerasimos Philippatos, who is very well known in heart failure. I think it's enough to say that he is the past president of the Heart Failure Association of the European Society of Cardiology and the past dean of the Medical School of the University of Cyprus. Professor Philippatos, sorry for the delay. The program is a bit delayed, but we are ready to hear you.
For the great honor, and especially the chair of the Congress, Professor Patrikios, and it's also a great honor that I have as chairs do really European leaders in heart failure and very good friends. So I'm jealous because I have to discuss about heart failure update, but it was clear from Dr. Drosatos that we have the future, and also from Dr. Drakos that we have the future in the heart failure management. But still, I think there is a need to discuss the current status of heart failure management in 2024. And as I've seen in the program, there will be other opportunities to discuss heart failure, and I think this is great for the physicians and the cardiologists in Cyprus and in Greece. These are my disclosures. I will cover the update in definition, medical therapy devices, and the prevention of heart failure. As you know, the current classification of heart failure includes 4 groups. Heart failure with reduced ejection fraction, with mildly reduced ejection fraction, with preserved, and heart failure with improved ejection fraction. I think this add of heart failure with improved ejection fraction help us understand better what Dr. Drakos presented in the beginning, but the other 3 groups, I think that they create confusion. Why? Even in the hands of a real expert like Dr. Barberis and Dr. Christodoulidis, the intra and inter-observer variability of the echocardiogram is more than 5%. So for the clinician, it's also difficult to understand why 38, the management in a patient with an ejection fraction with 38, should be different from a patient with an ejection fraction of 42 or 43. Moreover, from the registries, it is clear that at least 1/4 of patients, they move from the one group to the other. So I think that, and we'll discuss it more during the management, during the drug therapy, the advanced drug therapy, I think that in the future, the classification will go to 3 groups, but 3 different groups. All the patients with heart failure, from ejection fraction today from 30 to 65, they will receive the same therapy. And then we need to identify the patients with advanced heart failure that should be referred to a specialist center. And also we need to identify the patients that they have heart failure with normal ejection fraction. And in this group, probably more advanced, more exhaustive workup is necessary to identify if there is another underlying disease like amyloidosis, etc. We know that it's not always easy to identify these patients with advanced heart failure, but I think that we have markers. The acronym that is being used by Marisa Crespo-Leiro and other experts is this: I need help. And we can identify these patients because they need inotropes. They cannot uptitrate or need to decrease or stop the ACE inhibitors, the beta blockers, and the ARNIs. They have repeated hospitalizations, and this should be referred to the specialist advanced heart failure center. And for this reason, it's always useful a network, and this is available in Greece, even if it's at its early stages in some other European countries. I think that in the future, the heart failure clinics network will be an indispensable part of the management of these patients. What about medical therapy? It is always easier to identify the patients with heart failure and start treatment during their hospitalization. The main problem is that these patients, 40-50%, they have a preserved ejection fraction, 1/3 of them, 30-40%, they have atrial fibrillation, 40% of them, they have diabetes, 1/3 of them, they have chronic kidney disease and COPD. These are complex patients, and this is usually the reason, or this is the excuse that we use to explain why these patients with heart failure are not on optimal medical treatment. What historically we were doing is we started these patients on ACE inhibitors and beta blockers, then we edit MRI, then we replace the ACE inhibitors by ARNI, and recently we added SGLT2. One of the main problems of this strategy was that at 3 to 6 months, most patients were lost to follow-up. They were not only 15-20% of the patients were on 3 or 4 drugs, and also were in suboptimal doses. Recently, we have one more reason to start the treatment early, both in the EMBEROR reduced, but also in the DAPA heart failure trial, where epagliflozin and dapagliflozin have been tested in patients with heart failure reduced ejection fraction. It was clear that the benefit, the statistically significant benefit, started within the first 2 to 4 weeks. But is it safe to start all these drugs and uptitrate early? This has been tested in the strong heart failure trials. The usual care has been compared to the high intensity care, where all these patients should be uptitrated to the maximum tolerated dose very soon, under close monitoring and with the support, with the help of biomarkers. And strong heart failure, as you know, stop prematurely because of the increase in readmissions for heart failure and all-cause death in those patients treated in the usual care. And this has been accompanied by an improvement in the quality of life in this patient. What about HFpEF? This is from the European Register. And as you can see, what we do in patients with heart failure, preserve ejection fraction, we follow exactly the same treatment strategy. We give beta blockers, we give ACE inhibitors, we give MRAs, we give diuretics. And also, in the strong heart failure, there was a large percentage of patients with ejection fraction, left ventricular ejection fraction above 40, and the benefit of the high-intensity care was also present in these patients. And there is a recent meta-analysis of all trials by Greek authors showing that the more therapies we give in these patients with heart failure and preserve ejection fraction, this is from the group of Dr. Giannakoulas, the larger the benefit in these patients. How fast should we start treatment in these patients? It is not clear. Probably we need more data, but in the Emperor Preserved, as you can see, the result, the benefit was statistically significant within the first 18 days. What about devices? I think that management of heart failure becomes more and more difficult and complex. We have left ventricular assist device. We have also, and I hope that we'll have in the future, not only the artificial heart and expensive left ventricular assist device, those devices specific for patients with congenital heart disease or with other problems like the BiVACOR, but also cheaper devices like the PULVAD, invented by the late Professor Nanas, that is undergoing clinical trials. We have devices, as you can see in the left part of this slide, approved by FDA for the management of central sleep apnea with phrenic nerve stimulation and many others. I think that not only cardiologists, but I think other internal medicine specialists should become familiar with these devices in the future, because we'll see these devices more and more often. Something that is very useful if we want to prevent heart failure decompensation is the measurement of hemodynamics, continuous measurement of hemodynamics in these patients with heart failure. Of course, we advise our patients to measure weight, but as we can see here, weight change arrives very late during the course of the disease, in the course of decompensation, is just a few days before hospitalization. What it changed earlier is the filling pressure, the increase in filling pressures. And this is easy to measure, and this has benefit, this pulmonary artery hemodynamic monitor. There has been shown benefit in patients with reduced, but also in patients with preserved ejection fraction. One of the problems is that you need a system, it should be part of the national health system, the monitoring of these patients with these devices. There should be a system of follow-up that should react to the changes in this pulmonary artery hemodynamic monitoring, and this has not started yet in our health system, but I hope that this will start soon. Something that was always important in heart failure, but we start more and more to discuss about it, is are the patient's reported outcome, how the patient feels. In most trial, usually we measure all-cause mortality, cardiovascular mortality, heart failure hospitalization, repeated heart failure hospitalization. But recently, we start to discuss and try to evaluate objectively how patient feels. Of course, the patients want to feel better and live longer, but you know, these are very old trials where Lynn Warren Stevenson and several other advanced heart failure experts, they ask their patients if they are willing to change a percentage of the rest of their lives just to feel better, have better quality of life. And 1/4 of these patients with advanced heart failure admit that they wanted to have they prefer to have better quality of life. This is the reason that we start evaluating the health-related quality of life with some objective measurements. I don't think that we still have the ideal measurement, but this is the right way to go, because Carl Swedberg and Inger Ekman many years ago, 20 years ago, identified this problem for the first time. As you can see here, they ask the cardiologist to assess the patients and try to objectively present the status of the patients. You can see, and then ask the patients to assess objectively their clinical status, and you can see that there was a difference in the assessment between the cardiologist and how the patient feels. Last but not least is the heart failure prevention. These patients, there are patients at risk for heart failure, and these are the patients with hypertension, with a history of cardiovascular disease, with diabetes, patients with known exposure to cardiotoxic drugs, and also the patients with chronic kidney disease. And in my opinion, patients with chronic kidney disease and diabetes are not stage A, but are stage B. And what we try to do some years ago is to treat these patients, trying to improve cardiovascular and kidney outcomes. I'll present only the cardiovascular outcomes. These were patients that have been where a non-steroidal MRA has been compared to placebo, and in more than 13,000 patients it has been shown that there was an improvement in cardiovascular events, mainly driven by approximately 30% relative risk reduction in heart failure hospitalizations. And as you know, this led to Class 1A recommendation for the prevention of heart failure in patients with type 2 diabetes of the non-steroidal MRAs. What I think is important, what I've learned by the interaction with nephrologists and diabetologists during this trial is that in these patients, 65% of these patients, they had chronic kidney disease with GFR above 60, preserved GFR. And to identify the problem in these patients, it is necessary to measure urine albumin, which is something that we don't usually do in everyday clinical practice. 45% of these patients, of these 13,000 patients in this trial, they had a history of cardiovascular disease. 65% of these patients, they have preserved GFR. So these are patients usually seen by cardiologists. So I think it's important when we see a patient with type 2 diabetes and chronic kidney disease to measure GFR, but also screen the patients for albuminuria. And this will help prevent the episodes of heart failure. I think that I've learned a lot from this session by Dr. Drakos and Dr. Drosatos, and I see that the future is in the devices, not only left ventricular assist devices, but other devices that we use in the management of heart failure. But for the majority of patients, dear Vasilis, dear Thodor, dear colleagues, I think medical therapy is what we use, and this is the first step if we want to improve outcome in the management of prevention of heart failure. Thank you very much for the invitation and for your attention.
Thank you, Professor Philippatos, and congratulations for your presentation. We've seen some very important messages, and
I cannot hear you, Thodor.
I said thank you for your presentation and congratulations. Can you hear me now or not?
Βασίλη, Θόδωρο, δεν σας ακούω.
Can you hear us now? Okay, I think we should move to our next talker then, and I'll inform Dr. Philippatos that you have been listening to him, and so you can go on.
Now we will proceed with session 4, a cardiology interactive workshop. Commentators will include Dr. Thivos Simeonidis, Dr. Evagoras Ekonomidis, Dr. Kyriakos Kypreos, and Dr. Dimitris Richter. This session will feature 3 presenters, followed by a short interactive roundtable discussion where we encourage audience questions. At this time, we invite chairs Dr. Georgios Multidous and Dr. Theodoros Christodolidis to lead the session.
Hello, everyone. We're going now to proceed to the next The first speech is going to be by Professor Philip Galter, and it's a topic of pleiotropic effects of omega-3 purified fatty acids. Dr. Philip Galter is Professor of Nutritional Immunology in the Faculty of Medicine at the University of Southampton, UK. He's an internationally recognized researcher on nutritional immunology, the metabolism and functionality of fatty acids with an emphasis on the roles of omega-3 fatty acids. His research has both life course and translational perspectives. He was president of the International Society of the Study of Fatty Acids and Lipids, chair of the Scientific Committee of the European Society of Clinical Nutrition and Metabolism, president of the Nutrition, president of the European branch of the International Life Science Institute, and president of the Federation of European Nutrition. So, Professor Philip, it's very nice to have you with us, and we are waiting for your speech. Thank you.
Thanks so much. It's a great pleasure for me to be here at this meeting again. I think it's the third time I've been here, and it's always a very enjoyable conference, so thanks so much. So I've chosen to focus on my passion, which is omega-3 fatty acids. Of course, other types of fatty acids also have roles in determining cardiovascular risk, both positive and negative effects. And the omega-3 fatty acids of most importance, the most bioactive omega-3s, are the two shown here. EPA, eicosapentaenoic acid, and DHA, docosahexaenoic acid. These are very long-chain, highly unsaturated fatty acids. So you'll see they have 20 and 22 carbons in their chain length, and they have 5 or 6 double bonds within the carbon chain. So these are quite unusual properties. You're probably more familiar with saturated fatty acids, which are shorter without any double bonds. Monounsaturated fatty acids like oleic acid, very important component of the Mediterranean diet, 18 carbons with a single double bond. So these are quite unusual in their structure. That structure gives them particular physical properties. They're very fluid. They freeze at a very low temperature. So they have unusual and unique physical properties. But those physical properties also give them unique biological properties. So there's a link between the structural properties, the physical properties, and the biological properties. And this is very important when those fatty acids are incorporated into cell membranes. Because when EPA and DHA are incorporated into cell membranes, these could be cardiomyocytes, they could be hepatocytes, they could be macrophages, whatever. When they're incorporated into cell membranes, because of their unusual physical structure, they give those membranes a completely different physical property. And you'll be maybe familiar with the concept of membrane fluidity. That's the physical nature of the membrane. So membranes enriched in EPA and DHA are more fluid. Obviously, the chemical composition of the membrane has changed because it's enriched in those fatty acids. But also the phospholipids of the membrane, where those fatty acids are incorporated, create the environment in which membrane proteins function. Proteins like transporters, ion channels, receptors, and so on. And it turns out that the function of many proteins in the membrane is enhanced when the membrane is enriched in EPA and DHA. And of course, the membrane is the place that generates the signals that allow the cell machinery to communicate with the external environment. So gene expression is altered, protein production is altered, cellular responses are altered. And as I mentioned, these could be heart cells, liver cells, brain cells, inflammatory cells, and so on. So their functionality is altered when their membrane is enriched in these fatty acids. So just drilling down in a little bit more detail, I've mentioned these fatty acids are incorporated into phospholipids. This changes the fluidity. Those fatty acids within the phospholipids are also the substrates for the production of second messengers, like eicosanoids and other bioactive oxidized fatty acids. The phospholipids also create the environment where proteins move in the membrane, and there are structures called rafts, which are proteins that assemble together to form signaling platforms. Just coincidentally, there are also some G-protein coupled receptors that omega-3 fatty acids are ligands for. So this is just some detail of how the signals generated by the membrane are altered when the membrane is rich in EPA and DHA. And these signals, of course, affect cellular responses. I mentioned some of those impacting on physiology and pathophysiology. So through these mechanisms, EPA and DHA influence visual and cognitive function, metabolism, immunity and inflammation, oxidative stress, blood coagulation, function of the liver, the heart, the lung, the muscle, the brain, wound healing, and many, many other things. Now, we know that most people don't consume enough of these fatty acids in their diet. They come from particular types of fish particularly, and if people are not eating those fish, they have very low dietary intakes. And if the intake of EPA and DHA is low, the amounts of those fatty acids in people's blood, in their cells, and in their tissues are low. So the question is, what happens if people consume more EPA and DHA? And of course, they could do that by eating more of those fish, things like sardines, salmon, mackerel, herring, and so on, or by taking omega-3 supplements. And there are standard omega-3 supplements, fish oils, algal oils, and so on, but there are also highly concentrated pharmaceutical-grade preparations that can be prescribed for particular pathologies like hypertriglyceridemia, for example. So we know that if people either eat more fish, use more of those supplements, they have more EPA and DHA in their blood cells like red cells, white cells, platelets, and in tissues like heart, liver, and so on. We know the more EPA and DHA that's consumed, the more that accumulates, but we also know that this takes a period of time. A couple of caveats at the bottom here, that if people stop taking in EPA and DHA, so they stop taking their supplements, for example, they stop eating so much fish, those fatty acids will disappear over time. This is a hypothetical relationship between time and dose and the amounts of EPA and DHA that might be present, for example, in red blood cells, in platelets, or indeed in heart tissue. So what I'm showing is over time, with increasing dose, so this could be eating more fish, it could be taking more supplements, you get incorporation of these fatty acids, which plateaus at a level according to dose. So there's a dose-response relationship, and this takes a particular period of time, and this plateau will be reached at different times in different locations. For example, the plateau is reached more quickly in platelets than in red blood cells. So this is sort of hypothetical. This is actually a study showing incorporation of EPA at the top, DHA at the bottom into platelets over 1 year of supplementation according to different doses. So this is one of our studies we did in 210 healthy volunteers who were taking placebo. So there's no change over 1 year in the amounts of EPA and DHA if you don't change intake. And then there are 3 different doses of both EPA and DHA. So you see a new plateau is reached according to dose, and there's a particular time course of reaching this plateau. There's some other interesting details around that, but I don't really have time to go into that right now. So you can imagine in blood lipids, triglycerides, phospholipids, cholesterol esters, blood cells like platelets, red cells, white cells, you can get this incorporation. But what about tissues? So this is a study done by Bill Harris in the US, where he looked at the EPA and DHA contents of human hearts that were going to be transplanted. So to start with, there's a very low amount of EPA, there's more DHA, that's a characteristic, there's always more DHA than EPA. This is contribution to total fatty acids in the heart. These hearts were then transplanted, and the recipients consumed 1 gram of EPA plus DHA every day for 6 months through supplements. And then after 6 months, those transplanted hearts were biopsied again. And what this shows is 6 months of daily supplementation with EPA and DHA increases the amounts of EPA and DHA in the human heart. So this incorporation of these fatty acids happens in tissues as well. This is one of the few demonstrations that it happens in vivo in the human heart, but this has also been demonstrated through biopsies in skeletal muscle, in liver, in gut tissue, and in adipose tissue in humans. So the reason this is important is this relationship between the amount of fatty acids taken in, the amount in cells and tissues, and the health outcome. So this is data from the Nurses' Health Study, a big epidemiological study in the US, relating intake of EPA and DHA by quintile when these women were healthy at study entry to incident coronary heart disease, fatal coronary heart disease, and non-fatal MI over the follow-up period, of course with all the statistical adjustments. And essentially there's a dose-response relationship between higher intake of these fatty acids and lower risk of coronary heart disease outcomes. This is similar data from the Physicians' Health Study, this time looking at blood levels of these fatty acids. So the previous study was dietary intake. These are blood levels by quartile. And the outcome here is risk of sudden death in the follow-up period. So you see the higher the amount of these fatty acids in blood, the lower the risk of sudden death with all of the statistical adjustments. So there's a lot of these epidemiological studies relating dietary intake of EPA and DHA, or blood or cell levels of EPA and DHA, and coronary outcomes in follow-up periods. This is now almost, well, it is 10 years old. It's a systematic review and meta-analysis of those trials. So these are the aggregated data in that meta-analysis for dietary intake of different types of fatty acids and risk of coronary outcomes during the follow-up period. This is EPA and DHA within the box here. There are other types of fatty acids shown on here. So you'll see for omega-3s, there were 16 studies involving over 400,000 participants and 9,000 coronary events, with a 13% reduction in risk for those consuming the highest amount of EPA and DHA compared to those consuming the lowest amount. So the upper figure is dietary intake, the lower figure is circulating levels of those fatty acids, which are related to dietary intake, again now individually for EPA, for DHA, for the combination of EPA and DHA, and then for the intermediate in the metabolic pathway between EPA and DHA, which is DPA. Again, a lot of studies, 13 studies, 20-odd thousand people, 4,000 events, showing a risk reduction of somewhere between 20 and 25% in those with the highest level of EPA and DHA in their blood compared to those with the lowest level. As I mentioned, that meta-analysis was 10 years ago. There have been many more of these sorts of studies in the meantime. So this is a trial looking at total and cause-specific mortality in over 400,000 individuals, showing 15% lower cardiovascular disease mortality in those with the highest compared to the lowest quartile of intake. This is a pooling study of 19 different cohort studies looking at levels of omega-3 fatty acids in blood or in tissues and coronary heart disease outcomes in the follow-up period. So it's presented like a meta-analysis forest plot. It's a pooling study of relative risk of fatal coronary heart disease per 1 standard deviation increase in the levels of EPA in blood or adipose tissue. And essentially it shows that for every 1 standard deviation increase in EPA, there's a 9% lower risk of coronary heart disease in the follow-up period. And this is independent of all other factors that were adjusted for, including DHA. So there's a 9% reduction independently for EPA, and there's also a 10% reduction independently for DHA. So I was asked what a 1 standard deviation increase might be when I wrote a commentary about that particular paper and another paper published at the time. So using our own in-house data, I tried to work out what intake of EPA and DHA would be needed to get a 1 standard deviation increase in EPA in plasma phospholipids and in DHA in plasma phospholipids. So I estimated you would need an intake of around about 200 milligrams per day of EPA and an intake of about 400 milligrams per day of DHA. So if you put the two together, you would need about 600 milligrams per day of EPA and DHA for that 1 standard deviation increase, which might give you a 20% reduction in risk if you add the independent risks together. Now that's a little bit above most of the dietary recommendations, but it's not too far away from the dietary recommendations. Of course, in the meantime, there have been even more studies. This is one published in Nature Communications in 2021, again showing lower risk of cardiovascular disease mortality for those with higher compared with lower levels of either EPA alone, DPA alone, DHA alone, or the combination of EPA and DHA. So if you're interested, students perhaps, in reading more about this, this is a review now a little bit, 4 years ago we wrote, accumulating all of the data on EPA and DHA and cardiovascular health. But I think based on association studies, not randomized controlled trials, there's really strong and robust evidence that consuming more EPA and DHA, which will give you more of those fatty acids in the blood, is associated with a lower risk of developing heart disease. So the question is, how can that be? So you have to look at the risk factors for cardiovascular disease and say, well, what do omega-3 fatty acids do? So we know, I've shown with these ticks, the risk factors that are improved by EPA and DHA. So they lower triglycerides, they reduce postprandial lipemia, they improve endothelial function, they decrease thrombosis, they decrease inflammation, they impact cardiac rhythm, they decrease heart rate, but increase heart rate variability, and they have a small hypotensive effect in people who are hypertensive and not taking antihypertensive medication. So there are multiple risk factors where these fatty acids act. They do not lower cholesterol, which you often read about, but they impact a lot of other risk factors beneficially. And in fact, in Europe, health claims can be made on foods that contain EPA and DHA. These are approved health claims based actually on randomized controlled trials, looking at risk factors that EPA and DHA contribute to maintenance of normal blood pressure, maintenance of normal blood triglycerides, and the normal function of the heart. So a food manufacturer can put those claims on their foods if they contain a particular amount of EPA and DHA. And remember, these are highly regulated claims based solely on randomized controlled trial evidence. So I think taking all that together, there's no doubt at all that EPA and DHA act to optimize cell and tissue function and improve the cardiovascular risk factor profile, resulting in reduced risk of disease. So they have a very important role in prevention. I think there's no doubt about that, and that underpins the dietary recommendations and the health claims. The question is whether they have a role as a treatment for people who are already at high risk, so as secondary prevention, for example. And that still is much debated and is unclear and would take more than 15 or 20 minutes to try to sort out for you. So just to finish up, what I've told you is that EPA and DHA have to be consumed in the diet. We don't produce them very well ourselves. I didn't actually say that, but it's an important point. They're usually consumed in low amounts, and almost everybody in Western countries and many people in non-Western countries consumes less than the recommended amount. But if we increase their intake, that's reflected in higher levels in blood, in cells and tissues. And I showed you a very interesting example of the human heart that demonstrates that. They act through multiple mechanisms to improve cell and tissue function. Some of that is relevant to cardiovascular disease. So they improve the risk factor profile and reduce the risk. And so they have a role in prevention, but whether high-dose EPA and DHA can be used to treat people as a secondary preventative intervention is unclear due to inconsistencies in the literature. Just to the last point, cardioprotective effects are the basis of all dietary recommendations around EPA and DHA and these European approved claims. Thanks so much for your attention.
Thank you, Professor T. So we will not take questions right now. We'll have a discussion in the end of the session. Now I will invite our next speaker, who is Professor Kyriakos Kypreos from University of Patras medical school, who has a research interest in the pharmacology of metabolic syndrome, and he will talk to us about the interconnection between obesity and lipoproteins. Professor Cyprus.
Thank you very much. I have to say that I am super excited to be part of this fantastic congress one more year. I want to thank my dear friend Ioannis Patrikios for giving me the opportunity to be here today and deliver this lecture, mainly to the students of European University Cyprus. I have to say that just a few lectures ago, you saw Dr. Drosatos. He happened to be my very first student while I was a junior faculty at Boston University School of Medicine in the United States. And there is nothing more fulfilling for a professor to see his students really advancing and occupying positions, etc. So I hope that same is going to happen to the students of the European University Cyprus in the future. So indeed, today, I'm going to discuss some experimental pharmacology data that we have that prove a nice and very not so, let's say, intuitive connection between the lipid and lipoprotein transport system and obesity. Obesity is a health problem. It's a health problem because it is associated with many different diseases. And not only that, but we know that unfortunately it is associated with over approximately 13 different cancer types, and also with cardiovascular mortality. So obesity is not just an aesthetic problem, it's not the problem of how we look, but also it's a health problem because it impacts the quality of our life and the overall, the all-cause mortality, which seems to be also associated with increased BMI. For the longest time, I had been puzzled by the fact that in metabolic syndrome, which we research, obesity coexists with a special type of dyslipidemia. We have elevated triglycerides, reduced HDL cholesterol levels. Rarely we have increased LDL cholesterol, but most of the times we have elevated triglyceride-rich lipoproteins associated with subjects with metabolic syndrome. So I was always concerned whether this is just a random association or this has something more mechanistic in the background. So here, I would like to just remind everybody that the lipid and lipoprotein transport system is a very complex system. We have many different lipoproteins in circulation that carry many different lipids, and they all interact with each other. So if I have to explain this slide, I'm going to need a whole lecture today just to explain how these different lipoproteins interact with each other. I'm not going to do this. I'm just going to focus on one apolipoprotein, one protein that is found in these lipoproteins, and this is apolipoprotein E. The reason I'm focusing on this apolipoprotein is that it is found in many different lipoproteins, and also it is the natural ligand for the LDL receptor. If anybody tells you that triglyceride-rich lipoproteins, ApoB lipoproteins, are cleared through ApoB, this is a mistake. It is apolipoprotein E, which is bound to the ApoB-containing lipoproteins, to the triglyceride-rich lipoproteins, which will interact with the LDL receptor and mediate the clearance and the removal of triglycerides and other lipids from circulation. So this is a very important apolipoprotein that plays a very important role in modulating plasma triglyceride levels. And we know that if we don't have this apolipoprotein, then all of a sudden our ApoB-containing lipoproteins are increased. We have very high levels of ApoB lipoproteins, LDL, VLDL, IDL, and at the same time, we have an increase in atherosclerosis propensity. So we have a lot of atherosclerotic plaques forming, which usually they are highly calcified. So we know that this is a very important protein in modulating these ApoB-containing lipoproteins. In human, we have 3 different types. So we have 3 different isoforms, as we say, ApoE2, ApoE3, and ApoE4, which all differ at positions 112 and 158. And now we know that if we have mutations in this apolipoprotein, we have type 3 hyperlipoproteinemia, but also we have heterozygote familial hyperlipidemia. So ApoE plays a very important role, not only in the regulation of lipids, but also in the development of atherosclerosis itself. So everything started when we were conducting, I'm a lipidologist, so we were conducting some basic research studies on atherosclerosis. So we happened to feed ApoE deficient mice and other mice with a Western type diet, high-fat diet. And guess what? I mean, if this was a class, it's not a class, it's just a lecture, but if I was in class, I would ask students to identify the ApoE deficient mouse. The ApoE deficient mouse is the one in the middle, the one which obviously, you see, does not get obese. So this was a very first evidence that if you don't have ApoE, you do not get obesity. Whereas if you have ApoE, then all mice will start becoming obese, and if you have different types of ApoE, this type of obesity may be even more pronounced. So we wanted to know precisely how this is happening. So, of course, after this observation, many other groups also presented similar information stating that apolipoprotein E appears to be important in the development of central obesity, or visceral obesity, as we say, which is also associated with other comorbidities like diabetes, etc. So at this point, we started searching our books. We went back into like basic, let's say, anatomy, just to start understanding how things are. We remember about white adipose tissue, about brown adipose tissue. So we know that white adipose tissue is a storing tissue, is a tissue which is made to store lipids. Brown adipose tissue is a burning tissue, is a tissue which is made to burn lipids. And the difference between the two is mitochondria. So brown adipose tissue have a lot of mitochondria, and these mitochondria mediate oxidative phosphorylation and the burning of lipids for the production of ATP and heat. Whereas white adipose tissue doesn't have mitochondria, or has a few mitochondria, and as a result, it stores the lipids, it doesn't burn the lipids. And obviously, we know that many different diseases are rooted in mitochondrial dysfunction. So we know that if mitochondria doesn't work very well, then we start having important, let's say, dysfunctions, which eventually are going to lead to different types of diseases, including cardiovascular disease, like heart failure is one of these diseases that we heard before, cancer, diabetes. So we see that mitochondria is also crucial, not only for energy metabolism, but also for a disease state. And we know that we have strategies, there are strategies to convert white adipose tissue into brown adipose tissue. In other words, you can stimulate a fat-storing tissue to start burning lipids by increasing the number of mitochondria that are accumulated into this tissue. So just by thinking all this, and we started performing some studies just to give an answer of how this is happening. Of course, the obvious answer that everybody thought was taking place was that obviously ApoE binds to lipoproteins. Lipoproteins are bound now to the LDL receptor, and through this interaction, you may have this type of charging of adipose tissue with lipids, and as a result, you get obesity. But the answer is no. it doesn't happen. It doesn't happen because we know that if you don't have the LDL receptor, you still get obesity. So it's not an interaction as simple as the one that we just thought. And as a matter of fact, this study that we published in JLR became an editorial in ASBMB Today, an American journal, because indeed it was a paradigm shift. It was a paradigm shift because everybody thought that there is a certain way, but we saw that maybe there is another way. And this is something that was very, we take proud of this because we led the way into something which is very different. So we started investigating different cases in experimental mouse models. Let's say mice that don't have ApoE, mice that express ApoE, mice that express ApoE only in the periphery, or mice that express ApoE only in the brain, because we wanted to know if there is somehow some tissue-specific effect on on adipose tissue metabolic activation. And we were very surprised to find out that if you express ApoE in the brain, then mouse becomes obese. So that was the very first evidence that something may be happening which is tissue-specific. Now, if you express the same protein in the periphery, and this is something that we could do, for instance, with an adeno-associated adenovirus gene transfer strategies, we were no longer getting an obese mouse. So if you express ApoE in the periphery, the mouse doesn't get obese. If you express it in the brain, the mouse gets obese. And now we know that if we express different sites and different tissues, then we have a different type of effects, which I'm not going to discuss because, of course, I have very limited time for this presentation. But this gave us an idea. It gave us an idea that if we engineer a protein, an ApoE protein, we may be able to administer it in the periphery. Luckily, ApoE doesn't cross the blood-brain barrier, so if you inject it into periphery, it stays in periphery, it doesn't go to the brain, so it's not going to stimulate mechanisms associated with obesity, and it's going also to help the prevention of atherosclerosis. So by administering one protein, you may hit two different targets. So I want to tell you that many years back in around 2005 or 2006, I had engineered, while I was in Boston, a recombinant form of ApoE, by technologically modified form of ApoE, which at the time we were thinking of using for the treatment of atherosclerosis. And we know that this ApoE is very potent in clearing plasma cholesterol, so it lowers the levels of LDL cholesterol and ApoB-containing cholesterol. And it has a special property. It does not trigger hypertriglyceridemia. The reason is that wild-type ApoE stimulates secretion of ApoB lipoproteins, stimulates secretion of lipoproteins from the liver. So, and at the same time, if you express too much of it, you block lipoprotein lipase. You block the enzyme that catabolizes lipids, triglycerides in circulation. So in this recombinant form, had this special property to be able to still lower cholesterol without triggering hypertriglyceridemia. So we use this protein just to test the effects on the differentiation of pre-adipocytes to adipocytes, and we saw that it was lowering the differentiation of pre-adipocytes into adipocytes, mainly by lowering enzymes, by shutting down rather genes that were promoting adipogenesis. And then when we did a study in animal models, when we fed mice high-fat diet, and we did a study, we saw that in the beginning of the study, by administering this protein, we were able to stimulate mitochondrial burning of fat in brown adipose tissue. But when we proceeded to a longer treatment, we saw that we were able to start brownizing our white adipose tissue. We were able to start making more mitochondria into white adipose tissue using this protein and stimulate burning of fat in this tissue. Of course, this is some very encouraging data that we have, meaning that this recombinant protein that we have is capable of reversing the obese phenotype. And we know that this is a dominant effect compared to the wild-type ApoE, because when we use the ApoE knock-in mice expressing wild-type ApoE, we're able still to lose weight, and we're able still to stimulate mitochondrial function when they were expressing this recombinant form of the protein. And since we are pharmacologists, we started thinking of different methods of administering this protein. Currently, we are at the stage of using proteoliposomes, so you can make complexes of proteins with liposomes and inject them into circulation. We have a good idea that these liposomes have a very long half-life, about 15 hours, so we can administer once a day. And this protein is now patented, and we are in the process of hopefully developing it into a pharmaceutical product. So the quest goes on, and before I close, I want to thank everybody in my group who contributed to this project. This is a lifelong project. It's something which I take I have personal interest, and I take personal pride for the work that we do. And also at the same time, I want to invite anybody, any student from EUC who may have an interest in performing such type of research to come and talk to me, because I always have space in the lab for good people who want to do research. So thank you very much. And again, it's a real pleasure for me to be here.
Thank you very much for this perfect presentation. It's interesting. We have to proceed to the last speaker, which is Dr. Dimitris Richter. Dimitris is the head of the cardiac department at Euroclinic Hospital in Athens, Greece. He has a special interest in lipid treatment, coronary artery disease prevention, and treatment and thrombosis management. He served from many elected positions, including President of the Hellenic Lipidology Society, President of the Council of Clinical Practice of European Society, a member of Committee of Practice Guidelines in the USC 2016-2020. Dimitri, nice to have you with us, and looking forward to your presentation.
It is a pleasure to be here, and I will start without slides because they seem to have been lost somewhere. If we find them in the way, we'll see. What's after the standard lipid treatment, and what is a standard lipid treatment? Standard lipid treatment today is statin, ezetimibe, and PCSK9. So what do we have next? We have three different options. One is EPAs. You heard about DHA, EPA, omega-3, but let's say my point of view is a clinical one and not a research one. About 1989, so quite a long time ago, we had the GC study, which was 1 gram of Omacor, omega-3 combination EPA-DHA, which reduced sudden death in patients which had coronary artery disease. Big success, reduction of sudden death, reduction of cardiovascular mortality. After that, omega-3 started to have a role, and then started a huge program of Omacor, trying to show that it was really utile in different situations. And unfortunately, all the studies failed. all the randomized clinical trials failed. So that's when the majority of European state insurances stopped paying for omega-3, and they got out of the indication. One of the studies that was positive came from Japan in the past, and it was the jelly study, 2 grams of EPA. And it seems that somebody looked at it, and we had another big study with 8,000 participants in each arm, in which we had 4 grams of purified EPA. And the result was quite positive, reduction of all cardiovascular events. The type of patients, not found there? No, I gave it this morning from the stick to the girls and they passed. No, so the speech will be without, that's okay. And the group that was designed to participate in the study was practically patients with coronary disease or diabetics at high risk, which had triglycerides more than 150. FDA, considering the variation of triglycerides, told them they could put patients with triglycerides over 135. And the result was very positive. Independently, if we had 140 triglycerides or 200. So practically, we have a drug in which triglycerides serve more as a marker than as a pathophysiological mechanism, in which patients with this kind of metabolic syndrome do really benefit independently of how much triglycerides will be lowered. So that was a significant step on the cardiometabolic risk. The other is inclisiran. Inclisiran is, let's say, an mRNA PCSK9. The importance of it is that it helps incredibly in adherence. We have 2 injections per year instead of 24 with a classic PCSK9. So that's quite important. Why it does not have the whole market? Because yet, although it has various studies that it reduces LDL by 50% constantly in time, it does not yet have a cardiovascular study that reduces morbidity and mortality. The Victoria and Orion, I think, 8 study will be ready in 25-26, so we're still expecting it. And the first one, it came where it should be. That's okay, I'm finishing at any case. Yeah, you are absolutely right. I don't think you want to see this. Let's go directly to the last one. Bempedoic acid. That's new. And for me it is important for 2 reasons. One is it acts not like ezetimibe, it acts like a statin in the same pathway. What's really so practically in the HMG-CoA reductase? What's really different is that the activate bempedoic acid is not present in skeletal muscle. So we don't have myalgias. So first of all, there is a solution for all patients who present myalgia. And you see that the bempedoic is without any myopathies. So what are the studies? It has been tried on the matter of efficacy alone, which gives a 20% reduction, 23 as you see. It has been tried together with ezetimibe add statins, and when tried with ezetimibe, a high-potency statin, it gives a 15% reduction. So there is an add-on therapy, not as big as PCSK9s, but much, much cheaper. And we had the clear outcome study, or very high risk or secondary prevention, patients with LDL more than 100. And these patients were either intolerant to statins or unwilling. This unwilling, at least according to me, is like the woke agenda, that everybody must be equal and everybody can choose what they want. But you can't have a patient deciding, I don't want statins because I heard they are bad, so I don't want to try them. Because if we start this kind of logic just because bempedoic acid suits it, in this case, I would prefer to have Leqvio, which costs 5,000 euros every 6 months, instead of taking a statin every day. I don't think the word unwilling should be inside patient's choice. What can be is unable, because if you have a side effect, that absolutely respected, but not just unwilling because you heard that it's something bad. What did it do, bempedoic acid? It reduced LDL. Here you see a minor reduction according to what we expected, because more patients in the placebo group entered PCSK9. It reduced CRP, absolute risk reduction 1.6, which is very important, number needed to treat 63, very important, a very good drug, a new treatment for our armatory, different side effects. We have gut, we have cholelithiasis, and we don't have diabetes. So we have a difference, let's say, but I think we continue to be, as you saw, 2 out of 3 drugs are based on LDL reduction. And we are quite good now on LDL reduction. We had the omega-3 trying to get the cardiometabolic way. We have new drugs being tested for LPA. They reduced Lp(a) by 90%. If that provokes a reduction in clinical events, I hope we will be able to discuss it next November here, when the first trial will probably be presented. Thank you very much.
Thank you, Professor Richter, for giving us insights in the future, which is very close, I think. We have some commentators in this session. I don't know if they want to comment on the talks that preceded. Apparently, you are one of the commentators, so if you have any comments on the previous talks first.
I would like to ask Professor from Southampton, where is he? Why do you think we had such a difference between the EPA and the DHA studies? I mean, clinically, the EPA-DHA failed. When in the strength trial, they tried to measure the levels of EPA-DHA, of course, EPA levels increased and DHA level accordingly increased. Is DHA neutralizing EPA cardiac effects, or what do you believe? We don't know the answer. Thank you.
Fivo, if you want to make a comment or...
First, I would like to congratulate all the speakers for their exceptional presentation. I would like to ask Professor Professor, congratulations for your research. Do you feel that we are close to identifying new potential targets for the treatment of pandemic of obesity and atherosclerosis in real clinical practice? How would you identify the time horizon for that? Thank you.
This is a very good question. This is a very good question. Now we know already that there are medicines that have been affecting like semaglutide, for example, but at the same time they have been associated with side effects. And they're not made for everybody. So I think that for the benefit of obesity, we still need to learn a lot. And the reason we do this type of research is because we're trying to identify more factors that are specific for obesity. Semaglutide, for example, is effective medicines and anti-diabetic medicine, like a positive side effect in obesity. It would be nice to eat, let's say, the body target whereby regulating certain processes without causing significant down side effects, you'll be able to reduce overweight in a healthy and safe way. So the answer is yes. We are looking forward to many different products that are coming into the market. And now that gene editing also is a promising strategy, I think that in the near future we're going to also see, especially for morbid obesity cases, strategies of gene editing that will increase.
Okay. Thank you all for these perfect speeches, and we have to proceed on because we are late, so we'll go on to the next section.
Our session continues with a second interactive workshop, Current Trends in the Management of Aortic Disease, Thrombosis, Vascular Surgery. It's coordinated by Professor Mithidas Matsakis. Commentators for this session will include Dr. Triantafyllos Giannakopoulos, Dr. Nektarios Poulos, and Dr. Christos Dimitriou. We now welcome chairs Dr. Andreas Hadjipolikarpou, Gabriel Kotzanis, and Dr. Konstantinos Vazilis.
Good evening, everybody, and welcome to this session that is about a very important theme of the vascular surgery. So I would like to call to the podium Dr. Neophytos Zabas, who is going to talk about the contemporary treatment of abdominal aortic aneurysm. Dr. Zabas is a distinguished vascular surgeon here in Cyprus, very known doctor, with a great experience on the theme. Please, Dr. Zabas.
Dear Chairman, ladies and gentlemen, I would like to thank the organizing committee and especially Professor Patrikios for the kind invitation for this session. Unfortunately, my presentation, some are lost. So I would like to wait. So here we are. As it's a multi-thematic conference, I prefer to present a general approach of the treatment of the contemporary treatment of aortoiliac disease, the aneurysm. So as we know, definition of the abdominal aortic aneurysm is a localized enlargement of the abdominal aorta, usually exceeding 3 centimeters in diameter. And for the iliac aneurysm, is a dilatation of the iliac artery, typically diagnosed when it exceeds 1.5 times the normal diameter. As we know, the prevalence increases with age, and aneurysms are more common in males. The high risk of rupture, which leading to severe complications or death, is a major important. The weakening of the aortic wall and the inflammatory genetic factors are responsible for the creation of the aneurysm and the formation mechanism, and the risk factor are age, smoking, hypertension, and genetic predisposition. On these images, we can see the pathological, the disease of the dissection. On the first image, we can see the tear on the edemal, which divert the flow into the false lumen between the edema and the medial layer of the artery of the aorta. On image B, we can see the formation of the hematoma, intramural hematoma. On picture C, we can see the penetrating aortic ulcer. And on picture D, we can see a hole on the whole wall of the artery, so the blood flow is coming out, and we have the creation of the pseudoaneurysm. On the picture E, we have the dilatation of the whole wall of the arteries, and this leads to the formation of the saccular aneurysm. And the most common and well-known is the fusiform aneurysm, as we can see on image F. The anatomical classification of complex abdominal aortic aneurysm is based on the proximal extension of the aneurysm and their relationship with the renal arteries, the superior mesenteric artery, and the celiac artery. So when the formation of the aneurysm is below the renal arteries, we have the infrarenal abdominal aortic aneurysm. When it's very close to the lowest renal artery, we have the juxtarenal. When it involves the renal arteries, we have the pararenal and the paravisceral arteries. When the aneurysm involves the superior mesenteric artery, and more proximal extension of the aneurysm refers to the type 4 thoracoabdominal aneurysm. And the pararenal and the paravisceral trouble A's as known as suprarenal aneurysm. This is a classification of the iliac aneurysm, and we have 4 types depending the location of the aneurysm, and we can see the common iliac, internal iliac, both common and internal, and when involves the external iliac is type 4 classification by Reber. What's new this year is the new European Society of Vascular Surgery clinical practice guidelines on the management of abdominal aortoiliac artery aneurysm. These recommendations and levels of evidence are adapted from the European Society of Cardiology evidence grading system. So as you can see on the first table with the green color, we have the recommendation type class 1, and which is a stronger recommendation, and further down we have the 2, 2A, 2B, and 3 recommendation class, and on the table 3
we have the level of evidence. Level of evidence A is the strongest evidence, and this because the data derived from multiple randomized trials or meta-analysis of randomized trials. So what's new? Each section has been revised or rewritten. We have 160 new recommendations compared with the previous version of 2009, so we are 5 years after the last publication of the guidelines, including 7 Class 1 recommendations, completely new. We have 49 recommendations have been regraded or significantly rephrased, and 52 remain unchanged. And this is because increased knowledge about the trouble A's and the rapid technical and medical developments in the field. Although guidelines promote standards of care but are not a legal standard of care, they are a guiding principle, and the care delivered depends on patient presentation, choice, comorbidities, and setting, like techniques, available techniques, and local expertise. On this table, we can see the 7 new Class 1 recommendations, which refer to the training, the management, after the procedure management, the management of patients with Ehlers-Danlos syndrome, and the last one is the shared decision-making should be facilitated during conversation around abdominal aortic aneurysm screening, surveillance, and the management of large asymptomatic abdominal aortic aneurysm being considered for repair. The Chapter 11 refers to the shared decision-making with supporting information for the patients. So in these new guidelines, they are data and information for the doctors to the patients, because it's very important to inform the patients about their condition, the available data, the available treatment, the possible complication, and it's a shared decision-making. So the patient preferences are very important to be considered for the treatment option, and no decision about me without me is a motto adapted from the guidelines. Regarding the screening and the diagnosis, the screening is recommended for men aged 65 to 74 who have smoked, or they have relatives suffer from an aneurysm, and the gold standard is the ultrasound for the diagnosis. The recommended measurement is to measure the aneurysm from outer to outer layer to have a standard system of reporting the maximum diameter of the aneurysm, as you can see here on this image. The indications for treatment for men, the recommended size is more than 55 millimeters, and in women is 50 millimeters, and this difference is between the risk of rupture and the perioperative risk. Surgical risk is 4 times higher in women. That's why the difference to this indication. As we can see here, men with an asymptomatic abdominal aortic aneurysm of less than 55 are not recommended for elective repair, but this recommendation, although is Class 3 and level A, in women less than 50 is not recommended. Again, recommendation Class 3 and level C. And men with aneurysm of more than 55 millimeters should be considered for elective repair. Here, the recommendation is 2A. Further, as we said, for women is recommendation 23, and recommendation 24 refers to the patients who have a rapid growth aneurysm, and here the recommendation is for remeasurement as a first step, and then to consider the repair. The recommendation 25 has been changed and is referred to patients which are unfit for repair and should be considered for continued surveillance, referral to other specialists for optimization of their fitness status, and then reassessment. For our countries, Cyprus and Greece, this is a philosophical problem, and the family's wish and the patient wish should be taken care of, though. The treatment modalities and the medical management refers to the blood pressure control and lifestyle modification, and the surgical treatment is either open or endovascular. I will go through quickly. Here we can see the advantages and the disadvantages of each kind of repair. We have to say that the total surveillance in 3 years is the same after either open or endovascular repair. The open repair had highest perioperative risk and complications compared with endovascular, where the endovascular, the patients who underwent endovascular repair receive increased radiation, and they are in higher risk for further operations to prevent rupture. Some advances in trouble A treatment, we have the evolution of the fenestrated and branched or inner branched grafts, and the 3D printing for preoperative planning, and innovations. We have some implants for continuous monitoring of the blood pressure and the blood flow, and the use of artificial intelligence for rupture risk prediction. It's very important to perform this procedure in hybrid suites, which offers higher visibility, better monitor of the patient, lowest radiation, and give to the surgeons the opportunity to perform a combination of open and endovascular repair. Here we have some images of the fenestrated and branched, which will be presented later by Professor Matsagas. And I'm going to quickly present some case studies from our practice. The first case is an example of a successful endovascular repair. Here we have an infrarenal abdominal aneurysm with angulation and atherosclerotic plaque causing stenosis on the left common iliac artery. So we decided to treat this patient endovascularly, and here is the outcome with a good sealing of the graft, no endoleaks, and good outcome of the patient with only one night in the hospital. The second case is this case. You can see that the right kidney is much lower, and the right renal artery is origin from the sac of the aneurysm. So the plain EVAR in this case is not feasible because the right renal artery will be thrombosed. So the option here is either an open surgical repair with the reimplantation of the right renal artery to the graft, or a custom design stent graft. And we prefer the second option, and you can see here that we managed to introduce the graft to exclude the aneurysm and to connect the inner branches with all the visceral branches, including the ectopic right renal artery. This case, you can see a very bad aneurysm with thrombus and plaques to the neck of the aneurysm, and even not only close but above the renal arteries. So here we wanted to secure a proximal landing zone. In this case, the open surgical repair will require suprarenal clamping. So here we treated this patient again with an inner branching stent graft, and we managed to connect the branches with the visceral arteries. Another option for this case could be the fenestrated graft. This case includes the infrarenal aneurysm, as you can see, and bilateral internal and common iliac aneurysm. So in this case, endovascular repair will be much difficult because we want to secure the flow to the internal iliac artery to keep the flow in the pelvic arteries and to secure the spinal cord. So the technology gives us the evolution of the grafts, the possibility to treat this aneurysm with a bilateral IBD and infrarenal stent graft. And here you can see the result, the proximal landing zone, the good sealing of the proximal graft, and the patency. We managed to keep patent both internal iliac arteries. The fifth case, this patient is something we face increasingly the last few years. This patient underwent an open surgical abdominal repair in 2010 with a tube graft. He has been lost from the follow-up, and when he came to the clinic and we performed an ultrasound, we detected abdominal and iliac aneurysm, bilateral and internal iliac aneurysm. The aneurysms the iliac aneurysm, we are 6 centimeters in this case. So as you understand here, it's difficult for the patient to have a second open repair. It is difficult to keep the patency of the internal iliac arteries with open surgery. So for this patient, here you can see another image, a preoperative image. So it's a young patient, 65 years old. So we treated this patient with an inner branch to secure the visceral flow and the renal flow, and bilateral IBD graft. So with this solution, we kept the branches of the abdominal aorta and the internal iliac arteries patent. The outcome was very good. Here, when we did embolization of one branch of the internal iliac artery, unfortunately, the patient had an endoleak, and he came back for another embolization, and now he's fine. We published our experience with the precannulated inner branch endograft off the shelf. This is for cases we want immediate graft and we don't have the time to wait for a custom-made graft with a very good outcome. I will go quickly through the iliac aneurysm. The new recommendation here is to wait until 4 centimeters to repair the iliac aneurysm. And this is referred to the isolated iliac aneurysm. Here you can see the result of the treatment of isolated iliac aneurysm. It's very important the postoperative care and monitoring and the long-term follow-up to detect possible progression of the disease, endoleaks, infections, etc. In this picture, you can see the type of endoleaks. When we refer to endoleaks, we refer to the continuous blood flow into the aneurysm sac, which could be from proximal distal, from the connection, from the graft, or from the branches like the inferior mesenteric artery or the lumbar arteries. In this case, because of severe atherosclerosis of the iliac arteries, we did a conduit. So we did a short graft to the common iliac artery, and this gave us the opportunity to introduce the graft instead from the common femoral artery, from the common femoral artery, from the common iliac artery, and the patient had a successful endovascular repair of his aneurysm. One challenge is the horseshoe aneurysm. That means that the horseshoe kidney, I'm sorry, this is wrong here, when the kidney is just anterior of the aneurysm. So the open repair here is very difficult. Now you can see the kidney just in front of the infrarenal abdominal aorta. So this is a challenging case, how we can treat this aneurysm. The technology today gives us the opportunity to do a custom-made graft with the branches according to the CT scan, and we can treat this aneurysm and connect the branches of the graft with the renal arteries. This case is planned, but it has not been performed yet. The advances of the vascular aneurysm repair with the 3rd and 4th generation endografts give us a lot of advantages. We said about the guidelines. The guidelines are free, and for the students, you can search the Google for the European Society of Vascular Surgery, and you can download the guidelines if you have any questions, if you want to study for your exams. The complex aneurysm management is challenging, but we can achieve better results in our days. The centralization of care is included in the guidelines, and it says about that the patients may have better treatment in high-volume centers, and the medical and preventative approaches and research could help us to prevent the aneurysms. So these developments aim to improve patient outcomes, personalized treatment, and ensure the longevity of repairs while adapting to the complexities of aneurysm cases.
Thank you very much, Dr. Zabas. And I would like to... Okay, I would like to call to the podium Professor Matsagas. Professor Matsagas is a distinguished vascular surgeon, professor at the University of Thessaly, and he's going to talk to us about the endovascular treatment of aneurysm involving the thoracoabdominal aorta.
Mr. Chairman, dear colleagues, I have to thank from the podium Professor Ioannis Patrikios for this very kind invitation to be again here after so many years. We love to be in Cyprus all the time. As you heard before, the abdominal aortic aneurysm has become, the endovascular repair has become the standard of care in these patients, and this based mainly in the existence of the infrarenal neck that is about 10 to 15 millimeters. So the abdominal graft, the abdominal stent graft can seal in this infrarenal neck. But as you heard also before, a lot of aneurysms do not have this existence of the neck, so the aneurysm is developed proximal. And of course, there are the thoracoabdominal aortic aneurysms that combine the disease, the aneurysmal disease, in the descending thoracic aorta, as well as the abdominal aorta in various configurations, as you can see. And this complex aortic aneurysm, the standard of care till a decade ago, it was the open repair. But the open repair requires aortic clamping at least above the renal arteries, and this has a risk of renal ischemia and failure, and also a prolongation of the ICU stay. And sometimes these complex abdominal aortic aneurysms in open repair require even a thoracoabdominal incision and supraciliac clamping, and this is a risk not only of renal but also visceral ischemia and spinal cord injury in these patients. And of course, thoracoabdominal aortic aneurysms, open repair, requires thoracoabdominal incision and high aortic clamping with a risk of cardiac complication, risk of renal and visceral ischemia and spinal cord injury, and prolonged time in ICU and the hospital. As you can see of these slides, all these pictures are from my personal experience. So, coming to all of that, open surgery has the risk of hemorrhage and the risk of spinal cord injury because, as you may know, spinal cord reserves blood from several arteries, the intercostal arteries, the subclavian arteries, the internal iliac arteries, and the lumbar arteries. So despite the refinements in surgical and anesthetic strategies so far, and mainly in the last 30 years, these types of open surgery has still high risk of mortality and neurologic complications, mainly paraplegia after the operation. On the other hand, the last 2 decades, endovascular surgery offered to us several techniques, as you can see the slide, and you heard before from Professor Zambas. And these all techniques has the principle to extend the abdominal graft over the splanchnic level and at the same time perfusion of the feeding vessels. And the literature so far shows that more and more the results getting better and better with endovascular techniques through the time of these 2 decades. In this paper, it was a comparison between endovascular and open repair of this complex aortic surgery and found that endovascular repair has lower mortality, lower spinal cord injury, and of course, lower respiratory and cardiac complications. So the very recent European Society of Vascular Surgery guidelines changed their recommendation and said that the first-line treatment for this complex disease in the high-risk patients is endovascular one, and in the standard surgical risk patients have to be decided between the patient and the surgeon. And in my mind, in this decade, we've moved forward very quickly from the open repair to the endovascular solutions, and from this bloody field to a more remote access field. So coming to my first question to you, mainly in the students, What is the recommended way to treat complex aneurysmal aortic disease involving the thoraco-abdominal aorta? You can see several answers there. And if you can see in the guidelines, the right answer is that it depends on the surgical risk status and comorbidities of the patient. But to me, it seems that the endovascular way is the way to go the next year. And how we can do that, the endovascular repair, we have, as you heard, custom-made devices. What means custom-made? That the device is manufactured and designed according to the patient's anatomy, having the CT scan in head. And these are mainly fenestration devices, but also branch and semi-branch devices. We have also the off-the-shelf devices that are ready, and we have it in the hospitals. And this is mainly two devices, one from Cook and one from Artivion, two American companies. And also we have the technique of the parallel grafts, the chimney technique, as we said that. You can see some illustrations to highlight these techniques. This is a fenestration device with the bridging stent inside the target vessels. This is a branch device with branches instead of fenestrations. And this is the chimney technique to grafts in the renal arteries that allow us to deploy our graft more proximal than usual. And in the new guidelines, there is also a highlighted recommendation that we have to limit our coverage in the descending thoracic aorta in these reconstructions, because as much as the coverage, the bigger is the instance of paraplegia. And paraplegia and spinal cord ischemia is a devastating complication for these patients. It's of course less common in endovascular procedures than in open ones, but still is about 1 to 5%. And there is a lot of talks about the therapeutic versus protective role of cerebrospinal fluid drainage. And as you can see here, chimney technique does not cover at all the descending aorta. Fenestration devices, custom-made devices cover a very little portion of the distal descending aorta, while these off-the-shelf devices cover a lot of descending aorta, and this may lead to paraplegia even though they are ready to use in every hospital. This was the one I talked before. I'm sorry, but we have still these semi-branch techniques that are comparable to fenestrations. But we have not to use very frequently the off-the-shelf devices, but only in emergency situations, because as I said before, we have to cover a lot of descending thoracic aorta, and maybe this leading paraplegia in several patients. So my next question was, what is the most devastating early complication of the endovascular treatment of aneurysm involving the thoraco-abdominal aorta? And I think that everybody of you has understand that spinal cord ischemia is the worst one. And what is the best way to deal with endovascular treatment of aneurysms involving the thoraco-abdominal aorta? And I think also that you have understand that using the custom-made devices is the way to go in most of the patients. We at Larissa University Hospital, the last 8 years, we have dealt with 181 cases of complex aortic surgery. 75% of these patients were complex abdominal aortic aneurysms in the terms of juxtarenal, pararenal, or suprarenal aneurysms, and 25% of these was thoraco-abdominal aneurysms. We have dealt with them performing 76 chimney, 33 fevers, 67 BIVARs, and 5 combination of fever and BIVARs. And 152 of them were done in an elective setting, while 15 patients operated on a symptomatic basis, and 15 patients in a ruptured abdominal or thoraco-abdominal aneurysm. We have a quite very good success. And also our 30-day mortality was 6.6%, including the rupture cases, and our spinal cord ischemia was 3.3%. The mean follow-up is quite big now, and we have a lot of deaths, not aneurysm-related, but some of them also aneurysm-related, and quite good target vessel patients so far. So I'm going to finish my presentation with showing to you just three cases. One of these cases is a patient with a pararenal aneurysm with several right renal arteries in a unique anatomy that we treated them with a combination of two custom-made devices. And you can see here that this patient had three renal arteries from the right kidney. So we have to perform a fenestration device with three fenestrations for the celiac artery, the superior mesenteric, and the left renal artery. And after that, a distal branch device with two branches for the two main right renal arteries. You can see some pictures from the OR of these patients with the fenestration device first. We did the two fenestrations and left the last one for the end. And you can see after that the branch bifurcation device with the catheterization and bridging of the two renal arteries. After that, we have to bridge the celiac artery, and the final result was quite good. So after 1 year, this patient is in a very good condition with patient target vessels and just a small endoleak, one of the renal branches. We continue to survive him. In this second case, is a 66-year-old male patient with a prior aortic history. This patient had a lot of problems, very unique anatomy, had bifurcated a branch device for an iliac aneurysm in another hospital some years ago. We had a big inferior mesenteric artery, a left ectopic renal arteries, one from the right iliac one, the other from the aneurysmal sac, and also a left internal iliac artery aneurysm. So we treated him totally endovascular. First of all, the left internal iliac artery aneurysm with a technique that we have developed the last 2 years. We call it the Serib technique, with two stent grafts in parallel fashion in the branches of the iliac and the internal iliac artery. After that, the IMI embolization, the CMD deployment, and the anchoring of this device below the right renal artery, and then the bridging of the two left renal arteries from the pelvic kidney. And this is the result 1 year after the operation. The patient is also in a very good condition, with very good perfusion of the pelvic kidney in the left side, and also exclusion of the aneurysm in the internal iliac artery and the aorta. And the last case is this symptomatic thoracoabdominal type 1 aneurysm in a 77 years old lady, quite big aneurysm for a woman, a huge aneurysm, 9.3 centimeters. He came to the hospital from Thessaloniki, and we treated her with two thoracic devices and one of the self-branch devices, and also a tube graft for the abdominal aorta. You can see here the positioning of the two thoracic devices first. After that, the positioning of the T-branch from Cook, and then the T-branch and the tube graft for the abdominal aorta deployment. And at the other stage, we were unable to establish an access from the left subclavian artery because of the type 3 aortic arch. So we have to access from the right subclavian artery using a snare and a through-and-through guide wire in a quite difficult fashion, as you can see, and then bridging of the target vessels in the splanchnic aorta. And the final result was very successive, and the patient went home some days after the operation. And 2 years after, she is in a very good clinical condition, no endoleak patient target vessels, and no medical problems reported so far. So in conclusion, ladies and gentlemen, endovascular treatment of pararenal and thoracoabdominal aneurysms seems to be the way to go in the current practice, mainly because this endovascular treatment reduce mortality and morbidity and reduce spinal cord injury. Nowadays, there are enough endovascular solutions using mainly custom-made devices, but also combining branches and fenestrations as well off-the-shelf devices, and adequate experience, imaging and logistics, but also collaboration between vascular surgeons and manufacturing technicians are essential in order to succeed. Thank you very much for your attention, and I just remind you that next May in Athens we have the 73rd European Society for Cardiovascular Surgery International Congress that will be in conjunction with other 3 congresses at the same time, in the same hotel, in the same rooms, the Live 2025 and also the Aortic Live with a lot of live transmissions from all over the world, and also the Houston Aortic Symposium for the first time outside the United States. Thank you very much for your attention.
We'd like to thank the professor, and we'd like to call to the podium Dr. Mario Zertalis, which is a consultant interventional radiologist, director of Ultrasound Institute here at the University of Nicosia, and the lecturer of diagnostic and interventional radiology.
So, Mr. President, dear colleagues, thank you for the kind invitation. The first draft of my presentation was about 120 slides, so you'll be pleased to know that I've managed to sort of trim it down to 30 slides because this is a huge and complex topic. So I'd like to spend the first couple of minutes to briefly go over the latest guidelines and classification systems for aortic disease, and then discuss the management of type B aortic dissection. Now, our American colleagues from the Society of Thoracic Surgery and the American Heart Association have published guidelines on the management of aortic disease in 2022, followed by European groups in 2024, and they're all available free online. Now, one difference in the consensus between the 2 groups is the anatomical definition of aortic dissection. In addition to the conventional DeBakey and Stanford classifications, the Society for Vascular Surgery and Society of Thoracic Surgeons in 2020, they proposed a classification system where an entry tear in zone 0 is classified as type A, and an entry tear in zone 1 and distally as type B. Now, the European guidelines have endorsed the type, entry location, and malperfusion classification, and they describe a non-A, non-B aortic dissection for entry tears in zone 1 and zone 2 of the aorta. Both groups, however, agree on the chronicity of aortic dissection, with symptom onset in less than 24 hours being classified as hyperacute, between 1 and 90 days as subacute, and more than 90 days as chronic. And this temporal classification is reinforced by the changing pathology of aortic dissection. So if you look at the bottom right of the screen, you can see the serial changes in the morphology of aortic dissection, with an increase in total aortic diameter during the subacute stage at 6 weeks, followed by intimal thickening, flap straightening, and false lumen thrombosis during the chronic stage. We can classify dissection according to severity, either as uncomplicated with or without high-risk features, or as complicated in the presence of rupture or malperfusion. And the guidelines recommend for acute complicated dissection endovascular repair. And a number of techniques have been described dating back to the 1990s with the aim to restore true lumen normal blood flow to the aorta and its branches by excluding the primary entry tear, depressurizing the false lumen, inducing false lumen thrombosis, and promoting aortic remodeling. Now, Fenestration percutaneously has been described in 1990 in a 46-year-old man in Michigan who presented with chronic mesenteric ischemia 2 months following type B dissection. The patient refused surgery following diagnostic angiography that demonstrated a significant pressure gradient between the false and true lumens, as well as malperfusion to the right hepatic, right renal, and SMA branches. So the authors described a technique where, following catheterization of the true lumen at a point above the celiac trunk, they've punctured the aortic septum, and they created a fenestration using a 15-millimeter balloon between the true and false lumens, resulting in a reduction of the pressure gradient and improvement of symptoms. And subsequent groups demonstrated the benefit of this technique, and you can see pre and post fenestration improvement of the true lumen diameter. Now, the reason I'm mentioning fenestration is because the Michigan group have recently published their experience in 99 patients presenting with type B aortic dissection and malperfusion. And these patients, instead of having TEVAR, they received fenestration. And if there was persistent true lumen collapse or a significant pressure gradient, they received an uncovered self-expanding stent. And the author's rationale was that with fenestration and stenting, you have a zero risk of paraplegia and retrograde type A dissection compared to TEVAR. There is reduced risk of infection, and they also state that TEVAR as a single technique does not deal with static malperfusion. Now, talking about TEVAR, this has been introduced in 1999 by two groups, one in Germany and Italy and one in the United States and Japan. We've come to realize over the years that in some patients, despite achieving a primary tear entry seal, there may be ongoing symptoms, perfusion of the false lumen, and true lumen collapse. So Nienaber in 2006 described his technique, which he coded the petticoat technique, where he used a covered proximal endograft to seal the primary entry tear and extend with a distal bare metal stent to expand the true lumen and induce aortic remodeling. Now, this technique has been picked up enthusiastically by the Stable 1 and Stable 2 studies, where they investigated a dedicated dissection stent by Cook Medical, composed of a proximal covered stent and a distal bare metal stent in patients presenting with acute and subacute type B aortic dissection. And they demonstrated relatively high rates of freedom from aortic mortality, but a reintervention rate of 30%. To address this issue, because the petticoat technique relies on the passive outward force of the self-expanding stent, Hoferberth in 2014 proposed the stabilized technique. He used a compliant balloon to expand the covered thoracic endograft and the self-expanding stent, with the aim at rupturing the dissection membrane, creating a single aortic channel and eliminating false lumen, with an aim to improve aortic remodeling. And several groups demonstrated the benefit of this technique. For example, Zong in 11 patients with acute and subacute type B dissection and a median follow-up of 31 months demonstrated 100% complete aortic remodeling in the thoracic aorta and 83% in the abdominal aorta. And this is, I find this an interesting slide because it demonstrates the effects of the three techniques I've just mentioned. So in slide A, we have TEVAR, in slide B, we have the petticoat technique, and in slide C, we have the stabilized technique. So with TEVAR, we can achieve a primary entry tear seal, but distal to the covered endograft, you may have ongoing false lumen perfusion and expansion of the total aortic diameter. If you introduce the petticoat technique and a self-expanding uncovered stent, you can increase the true lumen diameter, but you may get re-entry from distal tears. With the stabilized technique and the use of a compliant balloon, you aim at creating a single aortic channel and eliminating the false lumen. Now, the guidelines are clear when it comes to the management of uncomplicated type B aortic dissection. in that they recommend optimal medical treatment. But this has been a matter of debate over the last years, especially following the results of a number of trials demonstrating some favorable outcomes in patients that received TEVAR instead of optimal medical treatment in uncomplicated dissection. However, the trials failed to demonstrate a difference in all-cause mortality. So the proponents of TEVAR would argue that optimal medical treatment suffers from medication compliance, loss to follow-up, and it has a disease progression profile where 30% of patients expire in 5 years and 24% require intervention, whereas the proponents of optimal medical therapy would argue that TEVAR carries a risk of stroke, spinal cord injury, retrograde type A dissection, and rupture. Regardless of the arguments, we're hoping that in the next decade or so, the new trials that are actively recruiting in Scandinavia, the United States, and the United Kingdom will provide level 1 evidence to answer that question. I just want to briefly mention about the patients with uncomplicated type B dissection and high risk, that when endovascular treatment is chosen, we should postpone, where possible, the procedure during the acute and subacute phases, as there is evidence to suggest that performing the procedure during the hyperacute stage, that is during the first 24 hours, it carries a higher risk of mortality. For complicated non-A, non-B dissections, open repair using the FED technique is recommended. And if the patient is not a surgical candidate and has suitable anatomy, endovascular repair is recommended, which is an interesting topic given the advancements in endovascular techniques and the development of aortic endografts. For chronic type B dissection, in addition to open repair, to address the issue of false lumen perfusion, a number of endovascular techniques have been described. Knickerbocker in 2014 in 3 patients with subacute and chronic type B dissection that were experiencing rapid expansion or rupture. He used a compliant balloon to expand the thoracic endograph and rupture the dissection membrane to obliterate the false lumen. Other techniques include the deployment of a dedicated candy plug device within the false lumen or using coils and plugs. Finally, I'll just want to close with mentioning about spinal cord protection. And there are guidelines that dictate left subclavian artery revascularization, especially in TEVAR covering zone 2, and to consider CSF drainage in patients that are high risk of spinal cord injury or if patients develop paraplegia after the procedure. There are some publications to suggest that permissive hypertension may have a greater benefit than CSF drainage in preventing spinal cord injury as well as alleviating symptoms of paraplegia. Thank you.
Our last presenter is Professor Eleni Arnaoutoglou from Department of Anesthesiology, Faculty of Medicine, University of Thessaly, Larissa University Hospital. And the lecture is Anesthetic Issues During Endovascular Aortic Surgery.
Okay, thank you. Thank you very much for your kind introduction. And I would like also to thank the organizing committee and especially Professor John Patrikios for this invitation and the opportunity to be here in this excellent scientific meeting. I will try to present you the anesthetic issues during endovascular aortic surgery in the next 10 minutes, I was asked. So let's go to the first question. According to the American College of Cardiologists and American Heart Association guidelines, complex endovascular aneurysm repair should be considered as a low-risk procedure intermediate risk procedure, high risk procedure, or the risk of the procedure depends on the patient's comorbidities. The correct answer is high-risk procedure, which means that the 30-day cardiovascular risk in terms of death and myocardial infarction is over than 5% without considering the comorbidities of patient. Dear colleagues, endovascular aortic surgery is really a challenge for anesthesiologists as we have to deal with elderly patients with several comorbidities that undergo an intermediate risk procedure in case of infrarenal EVAR, while complex EVAR and EVAR are high-risk operations. For this reason, it's very important to be an optimization preoperatively, and there is a need for anesthesia and cardiovascular specialization. The anesthesiologist should be able to manage a conversion to an open procedure if it is required, which means that he has demanding skills. The pre-anesthetic assessment and management of the patient should include the cardiovascular system, pulmonary function. The patient has to stop smoking for at least 2 to 4 weeks prior to surgery, renal assessment, the management of anemia, and also the assessment of nutritional status of the patient. And in case of frailty, we have to manage frailty. This is the other question, question number 2. What about the type of anesthesia for complex endovascular aneurysm repair? What is the best choice for these patients? General anesthesia, spinal anesthesia, epidural anesthesia, or monitor anesthesia care, which means local anesthesia under supervision of an anesthesiologist with a sedation. The correct answer is general anesthesia, in spite that there is limited evidence to show superiority of one technique over the other, and there is no difference in morbidity or mortality related to the type of anesthesia. It is obvious that comorbidities and surgical factors like the size, morphology, and position of the aneurysm and the estimated duration of surgery determine often the type of anesthesia. However, for long-duration procedures, like complex aneurysm repair, when access is often required from axillary or brachial vessels, it seems that general anesthesia is the best option for these patients as it helps to reduce patients' anxiety and difficulties associating for the patient lying flat for 3 to 4 hours. Local anesthesia or monitor anesthesia may be used for percutaneous approach, and local anesthesia, monitor anesthesia care, or regional anesthesia should be considered for unstable patients, frail patients, or in emergency cases. Now, regarding the intraoperative management, our main goals are to provide hemodynamic stability and preserve perfusion to vital organs, including brain, heart, spinal cord, kidney, and splanchnic vessels, to avoid hypothermia, in order for the patients to be able to be extubated by the end of the procedure, to provide adequate hydration throughout the surgery and renal protection, to control the blood pressure, especially at the time of stent deployment, monitor closely the ECT at baseline 3 minutes after heparin and every 30 minutes thereafter, and also to be prepared for major blood loss. Intraoperative management can be challenging not only because we have to deal with elderly patients with several comorbidities that undergo high-risk procedures, but also the access to the patient can be limited depending on the complexity of the procedure. As we can see in the slide, this is a picture for our operating theatre. There is darkness in the room, and limited visibility may delay perception of blood loss. For this reason, there must be an appropriate monitoring for these patients, depending on the duration of the procedure, the complexity of the procedure, and also on patient's comorbidity. However, invasive arterial blood pressure monitoring is mandatory. We also monitor cardiac output, cerebral monitoring. The use of central line is case-dependent for prolonged operations, complex cases, or frail patients. Suitable intravenous access is necessary to deal with massive blood loss. We should monitor also the urine output hourly and continuously temperature in order to avoid hypothermia. This is a flow track monitoring for cardiac output and cardiac index. Here you can see an air warming device between the legs of a patient in order to keep the patient warm. And recently, we have introduced 2 other monitors. This is a monitor for a continuous measurement of hemoglobin because we must have an efficient hemoglobin in order to avoid spinal cord ischemia over 10. This is a non-invasive monitoring by using the finger of a patient. And lastly, this is our next monitoring and the HPI, a prediction of hypotension monitoring. It seems that we can predict hypotension 3 to 5 minutes before hypotension happens to the patient. This monitor uses software and intelligent decision support software by invasive arterial waveform. HPI ranges from 0 to 100 with higher values indicating higher likelihood of a hypotension event. And you can see here this is in the left side of the picture, the monitoring. Also, you can see a drip of dexmedetomidine, a drug that we use in order to prevent postoperative delirium in these patients. With all these measures, we are able to extubate patients immediately in the OR. This is very important in order to assess if the patient has a paraplegia. However, a high level of care is needed that provides frequent neurologic assessments in the recovery room, continued hemodynamic support with maintenance of mean arterial pressure at the higher end of the autoregulation range. We should avoid hypotension that can result in impaired perfusion to spinal cord, kidney, and other organs. The patient in our department stays in the recovery room for at least 4 to 5 hours, and after this goes to the wards for at least 24 hours of close surveillance. And this is the last question as a take-home message. Which is the wrong answer this time regarding complex endovascular aneurysm repair. Patients are usually geriatric with several comorbidities. There must be anesthesia specialization or cardiovascular surgical procedures. One of the main goals is to avoid spinal cord ischemia. And the last is the patient should be transferred, intubated in the ICU. The wrong answer is the last one. The patient has to extubate in the operating theater. So in conclusion, ladies and gentlemen, for these high-risk patients that are undergoing the intermediate or high-risk procedures, there must be an expertised anesthesia team. There must be a pre-anesthetic assessment. General anesthesia is the best option for this patient. Also, interpretive adequate monitoring is mandatory in order to provide hemodynamic stability, maintenance of intravascular volume, and management of bleeding, renal and spinal cord protection. We have to avoid hypothermia in order for the patients to be extubated in the operating theatre. But I think that the most important of all is to establish a great teamwork. There is a need for a good communication, cooperation between vascular surgeons and anesthesiologists in order to achieve an excellent outcome. Thank you very much for your attention.
Thank you, Professor Arnaoutoglou. Thank you for all presenters for the great talks. We have no time for questions, unfortunately. Okay?